the CPC chairman, Dr. Abubakar Danraka, is by my right here, and next to him is Dr. Timipre, representing the CPAN national chairman. The CPAN national chairman is Dr. Maureen Nwafo. That is the Clinical Pharmacists Association of Nigeria, being represented by Dr. Timipre, the National Publicity Secretary. On my left here is the chapter secretary, Dr. Ebele Onwonchuluba, and next to him is Dr. Solomon Wanfuru, representing ASCOP. The chairman for ASCOP is Dr. Titilayo Onedo. She's ably represented by Dr. Solomon Nwafo. That is the Association of Consultant Pharmacists of Nigeria. So thank you very much. This press conference is, we all know why we're here. It is the 8th West African Postgraduate College of Pharmacists Nigerian Chapter Conference. And it's running through 12th to 14th of July. I want to welcome every one of us to the PCN Auditorium, Yaba, the venue of the 8th conference and AGM. We want to start this conference by the opening address by the chairman. My name is Afsat Adishino, a fellow of the Pharmaceutical Society of Nigeria and a fellow of West African Postgraduate College of Pharmacists. Good morning once again, everyone. We are delighted to announce that the conference is holding in this auditorium, the Pharmacists Council of Nigeria, Lagos State. Well, the conference is our annual scientific conference, the premier annual scientific conference that gather together all the consultant pharmacists, pharmacists from the social and admin, pharmacists from public health, pharmacists, specialists from the community pharmacy, and also the industrial pharmacies. So we are here with even all the older healthcare professionals. We've invited them, and we hope they will join us in this conference. We also expect academician, policy makers, and of course, the industrial leaders, and also our postgraduate students from the college. We call them the members, and they are the Postgraduate College of Pharmacists, either in the Part 1 or the Part 2. So we're inviting everyone to come to discuss with us emerging issues shaping pharmacy practice and healthcare delivery in Nigeria. The theme for this year's conference is expanding consultant pharmacists' clinical roles in Nigeria to optimize patient care and medication safety. And this reflects our commitment to strengthening patient-centered pharmaceutical care and ensuring that Nigerians benefit from the experts of our highly trained consultant pharmacists. Just like I said earlier, we have these pharmacists in the community referred to as clinical pharmacists in the community practice. We also have in the social and admin pharmacy, consultant pharmacists that work in the regulatory space, the administration space, and we also have those in the industry. So we are spread all over, and this is to benefit from this expertise. We call on our Nigerians to know that we have consultant pharmacists in these spaces that I've mentioned. And you can agree with me that the conference theme is apt. That is, what are the roles of these our clinical pharmacists to optimize patient care and medication safety? This is very, very important to the populace. A lot of medications are used, and we need to make sure that our Nigerians are aware of the safety and the benefits of this medication. A lot of things happen to patients because they take their medication wrongly, or they even self-medicate without knowing, and we come up with a lot of issues affecting their health. So this is a very good avenue, a very proper avenue to come together with other multidisciplinary team members in the healthcare system to make sure that we profile a way forward for the safety of our Nigerian populace. So this, I'll leave the CPC chair to talk about the things, the programs we expect within these 2 days of the conference. But before I do this, I want to thank the federal government of Nigeria for the implementation of the consultancy cadre. This implementation of the cadre has happened in some states. For example, we have in Katsina State, Niger State, Katsina State, and others. But we call on the federal government of Nigeria and to kindly help us with those states that are yet to implement this consultancy cadre. We have states like Lagos State that we are in has not implemented. We call on them to do this. We also have some teaching hospital like the Lagos University Teaching Hospital, Ahmadu Bello University Teaching Hospital, which we call on them to kindly implement this because it has been, the federal government have done this for us, done this for Nigerians, and we expect the implementation across board so that our Nigerians can benefit from this. The structure we operate in the Nigerian chapter, I also leave the chapter secretary to say briefly on that. So let me call on the CPC chairman to tell us what we expect from this beautiful conference. Thank you.
Thank you very much, the chapter chairman, members on the high table, and respected fellows and delegates of this conference. The conference is actually focusing on capacity building, abstract presentations. Today, as day one, we are actually having a very robust abstract presentations, oral and poster. It's good to report that we have about 21 scientific abstracts that have been peer-reviewed, and the authors have duly communicated on the presentation outline for such delivery. It promises to be very enlightening and also interactive in the sense that fellows for the next 2 days will be interacting with the posters that will be outlaid in front of the auditorium. Immediately after the oral podium presentation, we will go into the capacity building session. We have 2 important resource persons that will take us through the activity of improving our capacity in use of AI technology tools for research and pharmacy practice. The second session will cover how hospital and community pharmacists will use relevant tools to block the loop in antimicrobial stewardship. You will agree with me that a lot of antimicrobial stewardship issues are still very prominent in Nigeria, and we want pharmacists to take the lead in ensuring that there is good stewardship in the use of antimicrobials. At the end of today, the last session will be the interactive session, more like town hall meeting with fellows and the Association of Consultant Pharmacists of Nigeria. That session will be like a peer review interaction where consultants that have been so appointed from facilities that have those facilities that have been appointed will interact with those facilities, delegates from facilities that have not been so appointed, so that we can compare notes and see where the Nigeria chapter can come in together with the ASCOP to ensure that every nook and cranny of Nigeria consultant pharmacists are appointed and rendering their service. That will be the end of day one. Then tomorrow, which is the main event, we'll have about 4 sessions. The first session is actually the opening ceremony, where the keynote speaker, who is already with us, Dr. Mutihat Olulawal, will deliver the keynote on the theme of the conference. The conference is going to be chaired by our own Dr. Dere Awoshika, who we are duly informed that she had her mom passed away, and the burial is this week. So I'm using this forum to inform that she had sent in her apologies, and we do understand that definitely this is a very trying moment for her, and the national executive have also moved on to get the consent and approval of our own pioneer chairman of the chapter, in person of Dr. Ike, to chair the conference tomorrow. So equally eminent in his own capacity will chair the conference tomorrow to stand in for our own Dr. Dera Awoshika. Then immediately after the formal opening ceremony, there will be keynotes, there will be goodwill messages, and also remarks will be given by our dignitaries that have so indicated interest to participate. And there will be launching of our rebranded chapter newsletter in that session. Thereafter, we will go into the panel discussion. 2 panel discussions are scheduled with the relevant sub-themes on improving local manufacturing of medicines and also ensuring patient safety and medication safety. It will be moderated by our own expert, Dr. Chijioke Anya will moderate one session, and Professor Joda will moderate the second. After that, immediately, we will go into the AGM. The AGM promises to be very interesting because there are a lot of trends that the chapter needs to take account of and positions taken by the almighty AGM. That will be the end of the day, and departure will be tomorrow, as the case may be. Thank you very much for the opportunity.
Okay. Good morning, distinguished member of the press, fellows of the West African Postgraduate College of Pharmacists, invited guests present here, ladies and gentlemen. I am Dr. Ebele Onwuchuluba, the Secretary of the West African Postgraduate College of Pharmacists Nigerian chapter. It is my pleasure to give a little overview of West African Postgraduate College of Pharmacists Nigerian chapter. The Postgraduate College of Pharmacists was actually established to offer postgraduate education that is targeted towards improving pharmaceutical education, improving research, improving pharmacy practice. So the Nigerian chapter is actually a national chapter of the college, and its main objective is to support the activities of the college in advancing pharmaceutical care practices, improving skills among our pharmacists, and promoting medication safety and clinical skills among our pharmacists. And to improve or coordinate our activities, the Nigerian chapter operates the zonal, works through the zonal structure. And what do I mean by that? We have different zones in Nigeria. Currently, we have about 21 zones, and we have about 16 that are active. Okay, so we function through the zones, in bringing up programs that will benefit pharmacists. You can agree with me that last year we had a lot of world health programs. For example, the World Pharmacist, the World Pharmacist Day. We collaborated with Kano Zone to make sure that information is being transferred. Pharmacists came on board, and over 150 participants joined. It was really a very good outing. Likewise, different zones collaborated with us as well to celebrate different World Pharmacist Day, like World Diabetics Day, World Safety Day. And what we actually do is that we want to work with the zones to make sure that activities of the Nigerian chapter is well coordinated, and these zones are being manned by zonal coordinators, to enhance the activities of the Nigerian chapter and by extension, the college as a whole. So we are happy to be here because today is our scientific conference, and like the chairman and the CPC, they've already mentioned all the activities that will be happening today. I'm glad to be here, and I'm sure each and every one of us here are glad to be here. Thank you.
Thank you. Thank you very much, Ma. I think the press conference has come to an end, but as traditional with press conferences, the press that are here present will ask the chairman one or two questions, then we'll call and draw the curtain. So I'm aware Arise TV is here. Please, the reporter can come forward. Madam Angela from Punch is also here. Please come forward. Then Kaftan TV and who else? I think they are here. So, Farmer News. Okay, so Farmer News, please, I will hand over the mic to you. You introduce yourself, tell us the news agency you are representing, and ask the question. It's actually an interactive session with the chair and her panel. Please come forward. Let me start with our own Farmer News. Please bear with us. Thank you.
Thank you. My name is Romilo Ojalumo. I work with Farmer News. It's glad to see the topic of this conference. But the question is, it's been a while that this issue of consultant cadet has been on. Does it mean that this college has not really pushed, the way it should? Or what has been the major hindrance to the implementation of this so-called consultant cadet? Why is it this long? Why is it taking this long before the implementation starts? Because from what the chairman said, so many institutions, have not started, have not implemented the consultant cadet. Why has it taken this long? That's my question. Thank you.
So thank you. Thank you very much. Thank you very much, Farmer News, for your question. During my speech, I said we commended the federal government of Nigeria through the Federal Ministry of Health. We are not where we want to be, but we are not where we were initially. It might be slow, but really we are moving. And let me just briefly give you statistics that, yes, it might be slow, but we're going to get there. Because getting the implementation is right from the federal government. And it took our pioneers, our other ESCOs, our elders in the profession. They have really worked very hard before we even get to where we are. So we've gotten the implementation approval from the Federal Ministry of Health. So I think this is a very big one, and it's laudable. Now it is for us to get it domesticated, that is approved by the states. And as I mentioned, some other states, some other teaching hospital like ABU Teaching Hospital had implemented. We have other Federal Orthopedic Hospital, Dalakano. So we are moving. It's not that we are not moving. So let me quickly tell you that in the teaching hospital, at least we have 8 teaching hospitals that are implemented. The federal medical centers, we have 9. In the state hospitals, we have 11 out of 22. Even in the armed forces, we are not left. We have 3 of them, 2 out of 3 from the armed forces. And then the states, yes, we are moving slowly. 5 out of 36 is not good, but we say that we are not where we started. We have moved. And I know that calling on the states and the federal government, a lot of advocacies are going on, and we'll get there by the grace of God, to the benefits of Nigerians, not to the consultant pharmacy. We have a lot to offer. I just told you about medication safety, the theme of our conference this year. Medication safety is a big deal, and a lot of resources are lost. Even life are lost when people take drugs, their medication wrongly. And that is why we are still calling on the federal government, the state government, the federal institution that have not implemented to please go ahead and implement this to the benefits of Nigerians. Thank you.
Point. Okay. Before.
Let me have the representative of the ASCOP, the consultant pharmacist. He wants to add something.
Okay, thank you so much. The press, the high table, the fellows here present. I am not trying to say anything in disparity, but in concordance with what my chapter chairman said. I am coming in the line of ASCOP. ASCOP is Association of Consultant Pharmacists of Nigeria, ably chaired by Dr. Titilai Onedo and represented by Dr. Solomon Kelechi Nwafro, which is my humble self. There is a question the pressman asked. What is hindering the total implementation? I want to tell you one is a Nigerian factor, which you know. You can't rule out Nigerian factor in the implementation process. Consultant pharmacy practice is not a new thing. It has been there since 1960. It was removed by Professor Nyebu Chichuku when he came in, because when they see you as a consultant pharmacist, the physicians see you as a rival. But in Nigeria, we don't supposed to work as a rival team. We're supposed to work as a friendly team. You know, when you keep in a very intelligent person very close to you, if you don't have this good heart, you become to be afraid. Because your interest is like, that person is coming to take over your duties, which we are there to complement each other. There is nothing. But currently, we have over 50 institutions stretching within the state and the federal hospitals that are appointed pharmacists as consultant. And I want to tell you that issue that is strangulating the total implementation is withered in the way. And I want to tell you that we are moving in a speed of life, and in no distant time, it will be implemented in all the hospitals with the powers of ASCOP. And I want to tell you that consultant pharmacists runs on 4 pillars: clinical practice, leadership, duty, research and education. And our own is to complement the physicians and other healthcare team. It is not a fight. In countries in the world where it has been implemented, patients are enjoying it. In the United States, in the UK, in Egypt, and other places in the Western world. I want you people as a press people to help us galvanize, integrate with the state government, the federal government, to make sure it is total. And there we will get it for direct patient care. Thank you, and God bless us.
Okay, good morning, everyone. I have a question on the sub team. Though I will still have one-on-one interview with you soon. Okay, good morning, everyone. I am Angela Onzo. I work with the Punch newspaper. I'm the health editor. Sorry I came in late. I will still have one-on-one interview with you, sir, with your team. But I have a question on, based on the interactive section that you asked us to ask our questions. I have a question on the sub-team, the issue of local drug production. We have been on this for a while. I've attended a lot of conferences, a lot of advocacy on the issue of our nature of drug dependence. Over 70% of our drugs are imported. What should be done differently?
They are even using it already for this.
And NAFDAC
for this
to
course
reduce
already.
our drug dependency. We import 70% of our essential drugs, and even as we speak,
The same
there is
Nigerian
no
government
week
that will
that
not
we don't
encourage them.
report about stories from NAFDAC about fake malaria drug, fake
Chapter chair, please
What's
antibiotics.
let's
happening
mute
to
Of course, I
your
know you
Mute
talked about
everybody,
patient
please.
safety. We have irrational use of drug out there among patients. So what is your advice to them? But my main question is the issue of local drug manufacturing. Why are we not getting it right? We are talking about a lot of disease outbreak now. Still, we are nowhere near vaccine production. Of course, one of them is here for over many years now with bio-vaccine. Is nowhere. And sometimes when we attend press conferences or programs, we'll be told, oh, you press men, you are not doing enough. Why is it that we are not producing yet? What should be done differently for us to address the issue of our drug dependence, boost our local drug production, and possibly begin to produce a vaccine locally. Thank you.
Okay, with the permission of the chair, I think the question from Angela, also from Punch, is highly loaded, and I will invite you to come for our sub-team panel discussion tomorrow, because we have panel of experts that will address the key issues you have raised. But it's important to say that issue of local drug production, we are not where we are supposed to be. I must say that in drug production in country, there is what we call the primary and secondary and tertiary level of drug production. What is our reality is there isn't any pharmaceutical company in Nigeria that is producing the API, that is the active pharmaceutical ingredient. So active pharmaceutical ingredients, we are 100% dependent on importation, which is not what is supposed to be. There are a lot of interventions and initiatives by different organizations like EMZO and NIPRID to see how we can break the ceiling and the ice on API production. Coming to the secondary aspect of production, where Nigeria, with over 160 pharmaceutical companies, we actually just package finished pharmaceutical product. That is, when the API is imported, we just add the excipients and produce it as tablets, syrups, and suspensions, as the case may be. On that one, what the federal government in the last 3 years of this current administration has been doing is actually a good initiative, especially the PVAC, that's the Presidential Initiative on Value Addition to Healthcare System. If that has been what we have been doing in the last 15 years, we will not have been talking about this right now. The trajectory is, in the next 5 to 10 years, definitely Nigeria will be a leading local manufacturer of medicines if such interventions are sustained. What do we mean by such interventions? You recall that the federal government, through different interventions, usually have presidential interventions for different things as prioritized by the president of the federation. Take in reference the rice revolution, when the then President Muhammadu Buhari prioritized local production of rice to stop the importation. That was achieved during his term. Even during President Olusegun Obasanjo, if you recall the initiative of cassava production and local fruit manufacturing, we were able to attain self-sufficiency. So what is needed is such presidential intervention, which this current government has started through the PVAC, Presidential Initiative of Value Addition in Healthcare Production. With such interventions, because pharmaceutical manufacturing is very capital intensive, the returns on investments are not immediate. So if you do not have subsidy and waivers for due machinery and also importation of due technology, definitely we will not get it right. Lastly is to say that the issue of fake medicines is another burning issue. NAFDAC is trying its best with our porous borders. I must tell you, in the last 1 year, NAFDAC has been doing a lot of raids and going to where the productions are taking place. And with that, they are sanitizing the market. But we need Nigerians to also support. If you see something, say something, so that our regulatory agencies can function more effectively. As I said, we will invite you to our sub-team tomorrow, where regular experts, the chairman of NAIP is a panelist. We have an expert from NAFDAC and also another expert from the academia, so that the entire local manufacturing issue will be x-rayed and way forward will be presented. Thank you. Arise TV. Okay, Arise TV wants to do one-on-one with the chairman. TVC, do you have any question for us, for the chairman, please? Okay. Thank you very much. I think we have come to the end of the session, and Before, with the permission of the chairman, if CPAN wants to say one or two things that we have not covered, I think CPAN should say something also.
Thank you very much. My name is Dr. Ukerogene Agogo Timipre. I'm the National Publicity Secretary representing the National Chairman, CPAN, Dr. Morinoafo. When it comes to clinical pharmacies, expanding clinical pharmacists' role, CPAN has played a major role in this. CPAN, which was established in December 2019, and then in November 2020, they became an interest group of the Pharmaceutical Society of Nigeria. They are trying to make sure that all clinical pharmacies play expanded roles. What do I mean by that? In CPAN alone, we have 15 specialty groups, which covers what the West Africa Postgraduate College of Pharmacists is already doing. We have the 15 specialty groups, although in the college we have some of them that are grouped together, but in CPAN we have them individually, like the cardiology, endocrinology, nephrology. In the college, it is known as the cardiology, endocrinology, and renal. Then we have individual critical care and then nutrition support. But in the college, it is critical care and then specialized nutrition support. Then we also have other specialty group like infectious disease, oncology, and then all that. Then in CPAN, we make sure that all these specialty groups, they carry out different presentation every month, apart from the weekly presentation that CPAN also have every Friday. CPAN encourages clinical pharmacists to expand their roles in their different facilities. Now, clinical pharmacy is not only the ones in the hospital setting. We also have clinical pharmacy in the community setting and academic and also. Then the ones in the hospital are expected to take it far, because that is what, like the question that they asked concerning the drug production. Those people that are specialized in drug production, they don't just relax. In the hospital setting, they do a lot of local production. Even when drugs come in, they do quality assurance, assay, biochemical tests, and also chemical tests. So if you say your product contains 100, 1,000 milligram, we do chemical assay to find out that if it actually contains it. Also, we also do the micro test to find out if there is any organism and all that. So clinical pharmacy has a lot of role to play, and they do that a lot in the hospital setting. So CPAN is encouraging those who are clinical pharmacists to expand their roles by looking for a specialty to actually, nobody should just be a general pharmacist anymore. You should be in a particular specialty. Thank you so much.
So thank you everyone for this section, and we move quickly to the next section, that is the presentation of abstract. MC, please.
Thank you very much, ma. Dr. Elegbede, come and take over your session. Okay, hold on. High table, she wants a group photograph.
Okay, thank you very much. High table, let's quickly take the group photograph.
Thank you, iTable. Good morning, ladies and gentlemen. Can we settle down? Thank you very much. The press conference has flagged off the beginning of our 8th scientific conference of the West African Postgraduate College of Pharmacists, Nigeria chapter. It's a rainy Monday, 13th July 2026, and we are here at the 8th Scientific and AGM 2026 of the West African Postgraduate College of Pharmacists, tagged ECO 2026. A round of applause for every participant. We want to warmly welcome you from all over Nigeria and the diaspora for joining us in this scientific conference. It's very loaded, as the CPC chairman has reiterated this morning, and it promises to be very exciting. The theme for this year's conference is expanding consultant pharmacist clinical roles in Nigeria to optimize patient care and medication safety. So in this segment, we'll be looking at the various abstract presentation, both orals and poster presentation. But I would like to first establish protocols. The chairman of the West African Postgraduate College of Pharmacists Nigerian chapter, Dr. Afusat Adeshina. Can we all settle down, please? Can we settle down, please? The chairman of the Central Planning Committee, Dr. Abubakar Danraka. LOC chairman, Dr. Aderonke Olowu. The Abstract Committee Chair, Dr. Solomon Kelechi Nwafo. All members of the executive of the WAPC Nigerian chapter, all our zonal coordinators, all members of CPC, all members of LOC, fellows of the college, members of the college, all participants here seated, our invited guests, ladies and gentlemen. Once again, you are warmly welcome to this 8th scientific conference. So straight away, we are going to start with the abstract presentation. And can I warmly invite the abstract committee chair, Dr. Solomon. Are you ready for this section? Yes, please, I'm going to hand over to him. He's going to invite all the presenters this morning. Please, let's welcome him warmly. Okay. Is that one working?
Once more, I welcome all the fellows to this 80th scientific conference, because tomorrow will be the annual general meeting. This one is a scientific conference. So I am your abstract committee chairman. By my right is Dr. Ebel Onwuchuba, which is equally a member of the abstract committee. Dr. Danraka is a member too. Dr. Sikiru is a member. Dr. Habasin is a member. Maybe those ones are on the way, but because of time, we cannot keep on waiting for eternity. We need to start. So our normally the presentations we run. I don't know whether the presenters are here. The presenters, are they here? Because we are starting with oral. Are they here so that we can move on? Okay, let me know whether The WAPCP 082601. Is he here? On the way? No, I'm talking about the oral. Okay, is he virtual? WAPCP 082601. Is their own virtual or physical? Maybe he's not here. I hope he's not going to be pharmacy thing as usual. WAPCP 082612. Are you here? Are you here? Who is present, please? Let's know who is present. Okay. I'm talking about oral. Okay, ma. Can you start? Your slides, everything is here around, so that we can start with you. Okay, please, can you bring out her presentation? Let us start with the ones that are present. He said, no, the computer section. They'll bring it out. These are assessment guidelines. Yes. How many assessors are you? Yes, yes. How many are assessing? How many assessors? I mean, how many assessors? Wait, she can do it. No, there shouldn't be only one. Just look around anybody that can support to give them the guidelines. It's a weighted average. It's better. Okay, this person will do this person will be trying to get out the best. All right. Dr. Bello. Dr. Bello. It doesn't matter. Look at her. She's joined. You mean everything. Okay, but okay, it's here. Okay. Wait, thank God. He doesn't know you in person. Yeah, you just talk. I wait for you. I'm looking for you. Okay. Dr. Bello, please come to the high table so that we can do this in as fast as possible and go to another section. So how many presenters do you have? Is it not better we start with the virtual? Is there any person that is ready for this? Okay. No, this person is ready. I'll take your own. So she wants to. We can be doing it in 5 minutes. This is not supposed to pass more than 5 minutes. No, since we have time, give them 10 minutes, please. Give them 10 minutes. And also 2 or 3 slides. No, it's okay. So that at least we can maximize the time. No problem. So I'm not in that chat. Apart from the one person who said he wanted to Dr. Bello, please come to the high table. You are one of the assessors. You sent it to them. Even every other one, all the other abstracts. I sent to the abstract email now that we'll be using in communicating. That is yeah. That is what I'm saying exactly. Yes, my PowerPoint. I sent it to the abstracts. The abstract. Yeah, we can still forward it. She's in my laptop. She doesn't want to use WhatsApp. Don't worry, let her extract it. Just we have time. Just presenter and you are ready, please let me know. You are ready, let me know. Let me still keep on calling. It's like some of them don't even know their number. Maybe it might be the problem. They don't know. Okay, let me begin to call the topics. Maybe in my head. WAPCP 082601 is evaluation of the phytochemical toxicology and anti-lithiasis activity of the methanolic extract of Phyllotoms amarus in Western rats. The author here. Okay, the first author here is Aminu Sani Bichi, the corresponding author. Online, but it's not ready. Let me be calling them so that I be getting prepared. The second person is I don't understand the way these things work. Okay. The next person should be assessing hospital readmission rate and associated factors among patients with cardiovascular disorders at Ahmed Bello University Teaching Hospitals area, a retrospective study. The corresponding author there is Comfort O. Olirishe. Is it virtual or physical? Okay, virtual. Okay, let me be calling them so that they be getting ready, please, because we don't have time. Then the next abstract, WAPCP 082615, which is oral, feasibility of using quantum data tools in community pharmacies in Lagos State, Nigeria. The author there, corresponding author is pharmacist Godwin Emelie Emebina and Dr. Ayodepo Jagede. Is it virtual or physical? Virtual? Virtual or physical? No, I just want to know whether it is later decided. You know, some of them are changing their listing from being physical to virtual. This person is here. Some of them don't know their numbers. I'm calling the topic one by one. Or you forgot your topics too? I don't think it should be possible. Though. Let me reread. Feasibility of using quantum data tools in community pharmacies in Lagos State. Author is from Godwin Emelie Emebina. Please get ready. You are here. Okay, it's not here. Okay, the next one is abstract number WAPCP 082615 and is oral. Awareness and rate of utilization of NAFDAC Mobile Authentication Service, MAS, among health workers and consumers. A case study of Lagos Mainland Local Government Area, Lagos State, Nigeria. The corresponding author there is Musa Ado-Jibrin. Virtual, abi? It's like everything is turning virtual. I don't know why it's a problem. The next abstract is abstract number WAPCP 082617. The topic, the title is Strengthening Antimicrobial Stewardship through Expansion of Consultant Pharmacist Clinical Roles in the Intensive Care Unit of a Nigerian tertiary hospital. Okay, we are starting immediately. We're taking off. Let me just conclude this one. The strengthening antimicrobial stewardship through expansion of consultant pharmacist clinical roles in the intensive care unit of Nigerian tertiary hospital. The corresponding author is Idris BP. Please get ready. The person that is ready now, please start. Let us take off immediately. The assessors, please. If he's physical, please come and take the microphone.
The AC is working. Can just get you. No, I'm going to get you. Welcome.
Dr. Bello, please, you're one of the assessors. I know you are presenting, but you have to come here too so that we can do average later. Follow the guideline. Everybody, the three of people are assessing. Yeah. No, it doesn't matter. We'll keep the three together and then do average. Okay, you are presenting. You're not presenting. You just directed to make sure it works very well. It's not presenting. See the board, see the discipline so that you can.
Good man. I'm coming. Come on.
Are you ready? Ready, or is there still technical issue? Please, we have a consultant here. Dr. Bello is a consultant in anything that has to do with ICT. Please. Okay, finally, glory be to God. Okay, ladies and gentlemen, we are ready. The topic is evaluation of antimicrobial prescription pattern using World Health Organization aware classification in a secondary health facility, Abuja, Nigeria, by our own fellow, Dr. Ruth Fayashayo Ajayi. Please, can you have the microphone and do the justice to your presentation, ma'am? 10 minutes. 10 minutes.
Okay, the abstract committee chairman, other members of the committee, the Nigerian chapter ESCO, dear colleague, good morning. My name is Ruth Ajayi. I will be presenting the topic on the topic evaluation as it has been read. So because of time. So as a way of introduction, antimicrobial antibiotic or antimicrobial agent. Antimicrobial agent comprised of antibiotics, antifungi, virus, antiparasitic. Now I'm dealing on antibiotic. We know with the invention of penicillin, antibiotic has made a great impact. Despite the importance of it, it's always been abused. Antibiotic happens to be the most prescribed drug that we'll see based on research and what we have seen. And this led to irrational antimicrobial use, and this is a driver to antimicrobial resistance. We can see the body, the global burden of antimicrobial resistance. According to a publication in Lancet in 2024, we can see the body. That is the body, and a low and medium country like our country, Nigeria, we suffer about 90% of this impact. So therefore, to curb or reduce antimicrobial resistance, World Health Organization came up with what we call aware classification of antibiotics. And what is aware? A stands for access. Access group of antibiotics comprises of those antibiotics like penicillins, some macrolide like gentamicin, nitroimidazole, to mention but few. These are the ones that can tackle a wide range of antimicrobial, and they are less susceptible to resistance. While those in the wash group comprises of the second and third generation cephalosporins, fluoroquinolones. These are not supposed to be prescribed without sensitivity testing, and also the prescription of those groups should not be more than 40%, while the prescription of access should be about 60%, according to
World Health Organization. So the aim of the study is to evaluate the prescribing pattern of antimicrobial using World Health Organization aware classification of antibiotics and to qualitatively determine the factor that is influencing the prescription pattern in a secondary health facility in Abuja. The method of the research is a retrospective mixed study of both quantitative and qualitative method of study. Now, what happened? The antimicrobial prescriptions using the rational use drug of World Health Organization, 600 prescriptions were randomly collected in the secondary health care facility from July 2024 to June 2025. So the prescription were collected, it was inputted. Qualitative data was done through focus group discussion. The essence of the focus group discussion is to be able to identify the drivers that is influencing the prescription pattern. At this stage, there is need for the result to be projected. I can say, but the beauty of it is when it's being projected. Okay, now the result obtained shows that cephalosporins, the second and the third generation, were the most prevalent prescribed in the facility. Why? It follows by nitroimidazole, that is under the access group. The fluoroquinolones follows. So by the time we take side by side, the cephalosporins were about almost 300, about half of the 600 that were randomly selected. Now, when you come to the side, remember that the wash group of antibiotics, you have to do sensitivity testing before it is being used. The result of the sensitivity testing only shows that only 4% of the prescription that were sent for sensitivity testing, while the remaining 96% were not set for sensitivity testing. They were just prescribing. So that was what was observed. Now, when we look at the percentage of the access and the wash, the access was over 40, about 43 to 46%. That was the percentages. While the wash group, 53 point thereabout percent, about 53%. Now, when you look at the recommendation by WHO, it states that the access group should form 60% of the prescription. Why? That is the result. Why the wash group should not be more than 40%. So we can see it that the access category is 46.6, while the wash category. Look at the sensitivity testing, and this is what we are saying. So this shows that in this facility, they did not follow the guideline recommended by World Health Organization. So, and what this implies is that from the qualitative study, from the focus group discussion, among other reasons given for the prescriber not to follow the World Health Organization was that by the time they brought the patient will be in a critical condition through their interaction. They have abused antibiotics, so they felt that is their own word, that it might not be effective and for them to save life, as well as result coming late from the laboratory. So as such, there are gaps to be filled. So the gap to be filled in the next research, of course, there is need for awareness, both public, and that is one of the pillars of what World Health Organization recommended in the framework. So there is need for awareness, both within the healthcare providers and then the public. So these are some of the gaps that was identified. And if you look at it, this prescribing pattern observed from this secondary healthcare facility is in line with a similar study carried out in the southern parts of the country. So therefore, as a pharmacist, there is need for us to do awareness to be able to preserve the few antibiotics we have as research are not coming up. Lest I forget, the RE in their awareness represent those antibiotics on the reserve list. And these are not supposed to be prescribed unless with authorization from selected individual. So here are some of my references. Thank you very much.
Thank
you so much, Dr. Jai. That is within 5 minutes. You did justice to 8 minutes. Did justice to your presentation. Please, this is time for questions. Time for questions and maybe contributions. Disagreement with her or any other thing, please. Just only three questions. Just 1 minute. 1 minute time starts now. Questions?
There are still gaps to be filled. Please ask question or contribute or encourage.
Thank you very much, Dr. Ajayi, for this beautiful presentation. My name is Dr. Tijani Muftau. I want to ask, is there a forum where this presentation is made to the prescriber, especially? Enlighten them or teach them or collaborate with them the devastating effects of this antimicrobial inappropriate prescription. Thank you very much.
Hold on, Dr. Ajayi. I wonder whether you had ethical approval for your work at your facility. Yeah.
Yes. Okay.
Good morning, everyone. Thank you for your presentation. In your methods, you mentioned the use of qualitative study, focus group discussion. It seems I missed the results. Did you present the results? So what was your finding? If you could please recap on that. Thank you.
Sorry. I think your mic is on.
It's already 3 questions.
Oh, please, can you project this? So let me start from the last question. Okay, I would take the last question side by side with the first. The focus group discussion, is we have time limits and it's just summarizing on one slide. So the focus group discussion, the outcome of it was the reason. So this is the result of the focus group discussion. That was the finding. So why the focus group discussion? When the result, that is going to the first question from my colleague, when the results of the antibiotic prescription review came out, and with the result I got, with the access just be over 40% instead of at least 60%, while the wash group over 53% instead of there about 40 or less. So that was the reason for the meeting with the prescriber and other healthcare. It's not only the prescriber anyway, because we have the nurses, we have the pharmacists, all of them, they have their various duty. The question was asked, what did you do when you said this? What the problem, why we have the situation like this, even including the lab. Some of the results, because this is abstract anyway, so some of the results, like for example, the lab, the doctor complained that the laboratory, they sometimes give them the results that cannot be used. For example, a pediatric, they will use a adult drug to do the testing. So in a situation like that, there is need for education and awareness. So those are the things. And the focus group discussion, of course, was analyzed using Brown and Clark. So that was what was used. This is not a detail. This is just an abstract. So that was the result. Ethical, yes. Ethical approval was obtained from FCT Health Research Committee. So those are the answers to the three.
Dr. Solomon, there's one more question.
No, it's only three. Please.
All right. All right. She has answered the questions.
Thank you so much.
You can take a bow and go. Next presenter. I heard is virtual. Please present the one that is virtual. Waiting, please.
The one on his laptop.
After that person is Aliu Idris. Aliu Idris should be getting ready. Aliu Idris. It's like this rain is affecting.
Okay, while we are waiting for the. Okay. Please let us call the person.
Okay. Let me just call you now. Hello. It's your turn now. Can you share your slide from your side? Hello? Hello, can you share your slide from your side? Your turn now. This now. This here. So you will share your slide from that side.
So while we are waiting for our technical crew, I would quickly like to recognize the following people. We have Major General Stella Ibe from Nigeria Army. She's on the call this morning. Can we just celebrate her? Madam, you are welcome. We celebrate you. We also have in our midst the immediate past chairman of Comfy, in person of Dr. Adeyinka Ishola, who happened to be celebrating his birthday today. Hip, hip, hip. Thank you very much. Also, I want to recognize all heads of departments. Okay, all heads of Department of Pharmacy from Lagos State Health Service Commission. Are you here? Wave your hands. Yes, they are here. A round of applause. They are all directors of pharmaceutical services. All our zonal coordinators, WAPC zonal coordinators. Wave your hands. Yes, thank you very much for being here this morning. I also want to recognize yes, I've already written it. Yes. All ESCOs of the WAPC Nigerian chapter. Yes, so that's our vice chairperson, active and ever firing, Dr. Ruth Ajayi. Also here this morning, all LOC members from the chairman and members. I recognize you, all our CPC, for the wonderful job you have done. You are well, highly recognized. And especially this morning, we have in our midst the keynote address speaker for tomorrow opening ceremony. No other person than Dr. Motiyat Olulawa, DPS Osun State Hospital Management Board. You are welcome, madam. Thank you for honoring us and for being here this morning. On the call this morning, we have the Permanent Secretary of Health, Adamawa State Ministry of Health, Pharmacist Zira Matthias. Yes, welcome, sir. We appreciate you. So straight away, I'll hand over to Dr. Solomon again. The virtual presenter, I think, is ready.
What is the problem? Should I come over? Or does your system need antimicrobial stewardship?
Wait, can you? Sir, can you see my screen?
When we drove into the
You
Naima
can also
compound this morning, I just remember the hall where we used to take exams. Where we used to take lectures and then you do exam and you will sweat under several hours. So one time like this, we decided that I'm not going to take the exam and defend my project the same year. If not, I will fail both. So I decided to take it one after the other. So I spent more than 4 years doing West Africa, but today I'm a fellow. Peep, peep, peep. I'm sure that's the story of many of us. West Africa is not easy. To be a fellow is not easy. But those who are our members, be encouraged. You will get there.
Dr. Bello, I hope he's ready. Okay. Can you start? I hope you can hear us.
Yes, sir. Yes, sir. Yes, sir. All right. Standing on the existing protocols, I want to use that in my screen. Yes, sir. I'm with you, sir.
Okay. Share it, please.
Okay. Can you see my screen? I'm already sharing it, but I don't know why.
No, we can't.
Okay.
We can only see you.
Those of us before you can see your screen.
We are seeing your handsome face.
Some of us are seeing the screen. Oh, check your network.
Can you see it now, sir?
No, still not yet presented.
Okay. Well, I'm already sharing the screen. I don't know why it's not.
We can see it online here.
We can see it online. Can see it. Maybe
please, your screen is showing online.
Again. Stop and start again.
Go ahead.
Okay, so I should go ahead.
The screen is showing online, please. Yes, go ahead.
Or you take it down and share again.
Let me try that.
You may also want to off your video so that you can support
the presenter. Can you hear me? Can you send the slide? Let's help you share from here. Can you send it? Is it there? The slides, are they there?
Yes, sir.
Do you have the slides there?
See the slide now.
And
can you see the slide?
Yes, online we can see it.
Your name.
Hello, can you hear me?
Yes, we can hear you.
Your slide, is it on presentation mode?
Yes, sir. Yes, sir.
So what is the problem now? Send it to us, or tell us your name. Let's know that we can find it from here.
Okay. The author is Comfort Olurishe. So.
Okay, they didn't send
Assessing
it. Is it the Comfort
rates.
Olurishe?
Sir?
Comfort Olurishe, right?
Yes, sir. Yes, sir.
Why now? Okay.
I think the people online are saying that they can actually see my screen, but I don't know.
Let's know that it will work. Okay, good. Good.
Since they have a chat group for virtual, they should not send the abstracts to him. Then he will now give to
Oh, okay.
Is he ready, the presenter? Can he start?
Yes. All right. Good morning, everyone. Standing on existing protocols. My name is pharmacist Emmanuel Abifari, and today I will be presenting our research, which is titled "Assessing Hospital Readmission Rates and Associated Factors Among Patients with Cardiovascular Disorders at Ahmadu Bello University Teaching Hospital Zaria, a retrospective study." And this is the outline of our presentation. Now, to give a brief background of the study, according to previous research, hospital readmission is an important indicator of quality of healthcare, and any hospital readmission that you have has a great association with increased morbidity, mortality, and even healthcare expenditure, which often, for patients, especially with cardiovascular disorders, who often require prolonged and complex care. And this is according to Zhang et al. And Koch et al. In 2024. Therefore, identifying the causes and determinants of readmission in this group is essential for developing targeted interventions to improve patient outcomes and also to reduce avoidable hospital utilization. Now, what is our statement of research problem? We have divided into four. The first is talking about frequent readmissions, in the sense that CVD readmissions strain limited health system resources despite therapeutic advances, and this, according to Virani et al. 2023. Also, there's an evidence gap. You all will agree with me that most data that we have online originates from high-income countries, and they are not directly generalizable to Africa and even to Nigeria. And looking at our own tertiary institution, like the Ahmadu Bello University Teaching Hospital, there's the paucity of local data. So there's no empirical readmission data that exists for ABUTS Zaria. So giving rise to a need for us to conduct the research. And another one is systemic impact, in the sense that preventable readmissions, they cause bed overcrowding, resource strain and a lot of things, and this calls for us to carry out the research. Now, to justify the research, just in line with the problem that we talked about, we are looking at it from the perspective of, number one, the clinical quality, in the sense that there's a need to identify gaps in discharge planning, in inpatient management, and continuity of care to refine treatment strategies. And also there's a need for resource optimizations, just like I said. And once we get the data from our institution, it's going to guide the management to make some policies that are going to help for system planning and post-discharge care. And also for us as pharmacy, as pharmacists, when we carry out this research, we can see that there's a need for us to identify a gap that is going to inform a multidisciplinary pharmacist-led interventions in terms of medication reconciliation, adherence support, and post-discharge follow-up. So if we are able to have a research that looks at the hospital readmission rate and its associated factors, pharmacists can be able to come in to lead a multidisciplinary pharmacist-led intervention to look at medication reconciliation, adherence support, and even post-discharge follow-up. What is the aim of our study? The aim of our study is to assess hospital readmission rate and its associated factors among patients with cardiovascular disorders. The objectives are three. The first is to determine the hospital readmission rate among patients admitted with cardiovascular disorders. The second is to identify the most common cardiovascular diagnosis associated with hospital readmission. And then the third one is to explore the predictors of readmissions among patients with cardiovascular disorders in ABUTH Zaria. Our method was retrospective study, and it was carried out in cardiology unit medical ward ABUTH Zaria. The photos we looked at span from January 2023 to December 2025, and an ethical approval was obtained from the ABUTH research committee, and this is our ethical approval code. And the eligibility criteria that we used were adults that are above 18 years, those that were discharged alive from medical ward, and those that had complete records, that's the records that cover the diagnosis, medication chart. And this was the sample size, the sample that we worked with. The data collection procedure that we had was that we designed a structured pro forma, and then we translated it into an online format in form of Google form, and that was what we used to collect our data. And the pro forma asked questions that have to do with social demographics, the clinical diagnosis, comorbidities, the number of medications, the admission status, and all that they were in the pro forma. Now, looking at our results and discussion, looking at the patient demographics and cohort profile, the total number of patients that was used for this study were 83, and the mean age was 54.1 years. 59% of our patients were female, and 90% of them were outside, of course, showing the region in which we carry out the research. Now, looking at our first result that we are looking at the hospital readmission rate, we found out that the overall readmission rate stands at 19.3%. That is 16 out of the 83 patients that we looked at were readmitted. And crucially, we also observed that 68.8% of these patients or of these readmissions occurred within the 1 year mark. So now that demonstrates that the short-term 30-day monitoring windows that is standard in all the high-income countries is not going to be applicable for our context, for the Nigeria context. And this is in consonance with the study carried out by Oga et al. That did in Abeokuta heart failure registry, and then he found out that the hospital readmission rate for 30 days and 6 months respectively stands at 1.53 and 9% respectively. And this also agrees with another study by Aadzi et al. That carried out a Nigeria-Ghana heart cohort, and then he found that the highest hospital readmission rate that they obtained was about 9%. But this contrasts the study by Cork et al., in which he found that in high-income countries like South Korea, they had hospital readmission rate within 30 days at about 27%. And he also noted that the countries like US also have hospital readmission rate ranging from 21 to 25%. So we can see that this contrasts the global standard that they are looking at the short-term 30 days, but for our context, we can see from our study that there's a need for us to shift it to a long-term planning, at least there's a 6 months or 9 months post-discharge of our patient. And this is supported by our study. And then another one, looking at the drivers for readmission. Summarily, we discovered that heart failure, exacerbation, or decompensation accounted for 37.5% of the total readmission. So this stands as part of the drivers of readmission. But that is not even where I want us to focus our attention. Our attention is, I want us to look at the medication-related or non-adherence and also uncontrolled hypertension. And if we sum the total percentage of 25% plus 12.5%, we're going to see that the total percentage of medication related or non-adherence and uncontrolled hypertension give rise to a total percentage of 37.5%. And this is interesting because these two factors are actually modifiable. Looking at the medication related cost, for example, this is a critical gap that the pharmacists need to come in because this gap is highly modifiable. And if we can have pharmacist-led transitional care and adherence interventions, we can see that we will be able to really affect, or let me say, contribute to a large extent to the number of patients that are going to be readmitted in this setting. And also looking at uncontrolled hypertension too, according to a study by Tamimi Eta, it was noticed that uncontrolled hypertension, which is also sponsored by things like poor adherence, comorbidities, and even polypharmacy, are leading to some patients not to be able to control their hypertension. But if pharmacists can come up with some programs and some interventions, we can see that we'll be able to actually do, we'll be able to do a lot, and we are going to be able to reduce the total readmissions for the patient. Now, moving straight to the next one, we looked at polypharmacy and readmission, and summarily, polypharmacy was prevalent in 59%. That's 49 patients out of 83 patients at index admission at polypharmacy. And polypharmacy was defined as medications with 5 or greater than or equal to 5 medications. And the mean number of medications stand at 5.05 at discharge. However, even though patients with polypharmacy had a readmission rate of 24.5% compared to 11.8% in those without polypharmacy, even though this is higher, this difference was not statistically significant. And then looking at sex and hospital readmission too, male had a numerically higher readmission rate, 27.3% versus 15.2% for female. However, this also did not reach statistical significance. Now, looking at another thing that we found out in our study, which addressed one of our objectives too, looking at association between comorbidities and hospital readmission. This is one of the results that I really love the most because it gave us, it showed us that CKD,
please conclude.
Actually, all right. So from our study, we found out that a CKD patients had 16 times more likelihood to be readmitted, and this call for pharmacist-led intervention, especially for patients that are having cardiovascular disorders and also those that are having renal disorders. So if we can have interventions that target cardiorenal care, is going to go a long way to help our patients. This is our reference, and then thank you very much for listening.
Thank you. We need questionnaires, people that will ask questions before. I don't know whether you are there. Can you hear me?
Yes, sir. Yes, sir.
Okay. Let me do this little. Maybe I don't know whether my own is question or there, but it's a wonderful and a beautiful study. It's a good one. I am seeing bifurcation here. There is a title division. When you get to this place, there is a colon and there is a retrospective study. Don't you think this topic or title can go straight like this? A retrospective study on assessing hospital readmission rate and associated factors among patients with cardiovascular disorder at Ahmed Bello University Teaching Hospital. Straight like that without dividing it. Because I don't understand all this topic at times. When you write, you just put colon again, and most of the times, some of us that are equally in research, it doesn't go well with me. So I don't know. That it can be a straightforward topic. So then the second one is whether you can go to the hospital readmission That chart there, is it a bar chart or histogram? So there is something I want, if you can reproject. There is that your interval here or your follow-up here is not synchronizing. Yes, less than 30 days, less or equal to 60 days, less or equal to 90 days. Then it now jump to 1 year. The 1 year wasn't confined in a day or thereabout, because I know a year 365 days is not consistent. At a point, your unit of allocation changed from days to a year. Research is supposed to be consistent. That is the way it's supposed to be. So, more questions from the audience, please.
Okay, thank you for the presentation. My number one comment and question is on your slide 4. When you give evidence gap, that's the evidence gap reference you gave us 2014, Oga et al. 2014, is that data published over a decade ago, and you're using it for as a basis to identify gaps for your current study. It is, we consider it stale. A lot of studies may have gone between 2014 and now, so we expect something like 2020 something for a more recent update. So we are not looking at problems that have been solved in the past. Okay, that Oga et al. Was also cited in your slide 11. Now, my next question, my next observation is what has been said. You see, when you expand the timeline for readmission to 1 year, when you expand it to 1 year, patients with non-communicable chronic diseases, cardiovascular diseases, a lot of variables may have contributed to the readmission that are bucking into this consideration. A lot, as outside the initial management, adherence, polypharmacy, whatever cost you looking at, over the time period of 1 year is so much that so many things may have intervened in the period to result in the readmission you're looking at. So those other health systems where they look at a 30-day timeline, it's more realistic so that if you make an intervention, it will have direct positive outcomes. Okay, so those are the two comments I have. Thank you.
All right, thank you once again. My name is Tijani Muftao. My observation or suggestion is in the area of drivers of readmission. So I don't want us to limit our role to just those three. We are very important in all the factors that could contribute to readmission. That is just my own contribution. Thank you very much.
Next person. Gender sensitivity. No lady. No lady. Okay, no problem.
Okay. Yes, we're not attacking, we're just rubbing minds. The same slide where you have the duration for readmission, there's a figure you quoted there, 68.5%, 68 point something percent. I couldn't add up that figure from the chart that you showed. So because the figure, you should be able to get that figure from that particular chart. It's like it just came from somewhere else. Thank you. If you can address that.
Can you answer your questions now, please? So that we can
Yes,
move
sir.
to
Yes,
the next
sir.
person.
Okay, quickly, let me do the first one. Thank you, sir, for the recommendation on the topic, and then we are going to look into it. Thank you, sir. Also for the reference for Oga et al., we actually did a lot of literature reviews, and we did not see even much data today, especially that has to do with this kind of study, readmissions, cardiovascular disorders, and all that. But it's also well noted, sir. Thank you so much. Now, for the year and then the days, the disparity is also noted. Thank you so much. Now, just to address the last question, sir, for the overall readmission, where we quoted at 68.8%. If you look at the figures, I would say 68.8% of this readmission. So if you recall, we said we had 16 patients that were readmitted to overall, and that was 19.3% of the entire cohort. However, when you now look at out of these 16 that were readmitted, now, if we now break it into percentage, 68.8% of these 16 were readmitted within the 1 year mark. And also, the reason why I thought somebody was even going to ask that, why is it that the one for 30 days, 60 days, and 90 days were the same? Actually, the readmission that had 4.8% occurred for between 0 to 60 days, we had no readmission. Then also from 60 to 90 days, there was no readmission. But however, since the result was presented in a cumulative format, so that means that if we are going to consider, for example, patients that were admitted for 60 days, we have to look from 0 to 60. Also for 90 days, we have to look for 0 to 90. So that was why we had the same thing. 4.8% of the patients that were readmitted, of the entire cohort were admitted between 30 days. Same thing goes for 60 days. Same thing goes for 90 days, and then 20.3% of the entire cohort of the 83 were also readmitted within 1 year, and greater than 1 year, 6%. However, if we look at only the patients that were readmitted, that is where this 68.8% comes into play. So that would be over 16 now, not over 83, sir. Thank you.
I will consider you because I've actually concluded the section, but I will consider you so that there will be a balance.
Thank you so much. Good morning, everyone. I was thinking that I was going to say something about drug monitoring, because I've not seen the relationship with pharmacists, in the intervention of pharmacists in this presentation. I'm assuming it's supposed to be related to pharmacy, because we are trying to talk about ourselves. So have you thought of how maybe people are not taking their medication properly, or what was the monitoring, drug monitoring in this case? Maybe you could use it to expand your work so that it could be related, because readmission, CBD readmission, so what for us pharmacists? So what's the link with their drug therapy? That's a way to expand. It doesn't have to be part of it now, but you could consider it later. Thank you.
Thank you so much. Please answer your question so that we can move to the next.
Okay. Thank you, ma'am. Regarding the relationship between this study and pharmacists, if we look at one of the results that we presented, we showed the relationship between polypharmacy and readmission, and we'll note that from the data that we took, the patients that were admitted that had polypharmacy were actually more than those that do not have polypharmacy. However, it was not of statistical significance, but that doesn't mean that we as pharmacists, because of course, if a patient is on polypharmacy, it means there's likelihood for more drug-drug interaction, even maybe drug-disease interaction. The issue of non-adherence also comes into place. The issue of pill burden also comes into place. So that is a point for us to intervene as pharmacists. And also, if we go to the last, the result that we talked about, relationship between the comorbidities, you realize that we noted that the patients that were having CKD, that's chronic kidney disease, they had 16 times likelihood to be readmitted compared to those that just had other comorbidities. And when in ABUTH here, we actually have specialty teams, and one of the things we do is that there are pharmacies that are allocated to, for example, the renal clinic now. So what we are trying to propose is that we as pharmacists, if we can have a pharmacist-led intervention that we consider cardiorenal axis now. So patients that are having cardiovascular disorders, and this same patient is also having CKD, from our data, is already clear that that person is 16 times more likely to be readmitted. So that is where pharmacists that specialize in cardiology and renal clinic can come into place, and also liaise with physicians that are in renal clinic, the cardiology, so that we can be able to come up with a much more comprehensive planning and also care for them. So this is another point of intervention for us as pharmacists. But also, Ma, your contribution is also well noted, and we are also going to consider it in other studies. Thank you.
Okay, thank you so much. The next presenter. Online, yes.
Can I introduce some? So while we are waiting for the technical crew, we'd like to warmly welcome all our delegates again to Lagos, and those on a virtual call. We thank you for joining us this morning. We want to again welcome all heads of pharmacy institutions, all our HODs. You are welcome here, both here and in various institutions watching online. We want to specially recognize the former Herbs Chairperson National in the person of pharmacist Victoria Uku. Madam, you are welcome. We love you. Also on the call is Dr. Titi Onedo, the chairman of ASCOM. ASCOP. Yes, let's celebrate the Wonder Woman. And I have the privilege to welcome and recognize the mama of our Nigerian chapter in person of Margaret Obono, mama, grandmother of WAPC Nigerian chapter. Please warmly welcome her. She did a lot of work, a foundation, and also building, and still building. Okay. And then also, I have here this morning as well, all the way from the University of Ilorin, Pharmaceutical Sciences Faculty, Professor Kola Mustafa. You are welcome here, madam. Okay. It's my singular honor to welcome and recognize our former WAPC Nigerian chapter chairman, a vibrant, and I say vibrant, bulldozer, always finding a way where there is no way. The former chairman of WAPC Nigeria chapter in person of Dr. Onyea Chijioke. He fought and fought, and we can say that you have done very well. Thank you, sir, for coming. So straight away, are we ready? Okay. So while we are waiting for the next presenter, who is also virtual, we want to warmly welcome all our participants online. We thank you for joining us. I think you can see that the call is filled up. Yes. And then we also want to recognize various delegates from various places, from the South. All the South people, shout one go, sir. From Port Harcourt, from Bayelsa. Oh yeah, keep shouting go, sir. Thank you very much. You can see that they are here. From the northern part of Nigeria, we want to warmly welcome you. From Kamsina, from Kaduna, from Taraba, all over. You can see people are here to commemorate and celebrate Nigerian consultant pharmacists. I want to welcome you once again, all the way from Ilorin. Yes. Okay, Gosa. Northern delegates, Gosa. Okay, Nasarawa. Okay, you are welcome. From Niger, you are welcome. From the eastern part of Nigeria, I know people have moved in since yesterday. We want to warmly welcome you. And then the western part, Lagos people, celebrate yourselves. From Ibadan, from Osun State, we welcome you. Ekiti. Okay, where else again? From Abeokuta, yes, we are so glad that all over Nigeria. Nigerian pharmacists are doing great things. So are we set? My vice chairman, Nigerian chapter, I think we have called so many people today. Okay, celebrate Dr. Solomon. From where east. We are happy about this attendance. And then we know that by tomorrow will be more people will be here. People are already flying in, and people flew in and drove in, and people walked in, and we are celebrating the grace of God for today. All right. The next presenter, predictors of drug therapy problems and acceptability of pharmacist interventions among hospitalized patients in the medical world of why is it ABU? The 3 presentations today have been ABU. Okay, we celebrate ABU. All right, over to you, technical crew.
Hello, sir. I'm in. Yeah, hello, sir. Yes, sir. I'm ready. All right, sir. Okay. Thank you very much for the time. My name is Pharmacist Aminu Sanibichi, and then I'm presenting on the topic, predictors of drug therapy problems and acceptability of pharmacist interventions among hospitalized patients. Hello, sir. Hello, sir. Hello, sir.
Please go ahead.
Okay, ma'am. So, I'm presenting on predictors of drug therapy problems and acceptability of pharmacist interventions among hospitalized patients in the medical ward of Ahmadu Bello University Teaching Hospital. I'm Aminu Sanibichi, and then this is the outline of the presentation. So by way of introduction, drug therapy problems are events or circumstances involving drug therapy that actually or potentially interferes with a desired healthcare outcomes. And pharmacist interventions have been shown to improve medication safety, optimize therapeutic outcomes, reduce medication-related harm, and enhance quality of patients' life. And despite the growing implementation of clinical pharmacy services across the globe, there evidence on predictors of DTPs and acceptability of pharmacist interventions remain limited in low-middle-income countries like Nigeria. So, statement of the research problem. Clinical pharmacists identify drug therapy problems and recommend interventions aimed at improving medication safety and therapeutic outcomes. However, the clinical impact of these interventions largely depends on their acceptance and implementation by prescribers and patients. Evidence regarding predictors of drug therapy problems and acceptability of pharmacist recommendations in Nigerian tertiary hospitals remains scarce. And this knowledge gap limits the development of evidence-based strategies for identifying high-risk patients, prioritizing pharmaceutical care services, and strengthening interdisciplinary collaboration in medication management. So now justification for the study. Number one, this study provides locally generated evidence on patient-related predictors of drug therapy problems and also evaluate the acceptability of pharmacist interventions in a tertiary healthcare institution. In this case, it's Ahmadu Bello University Teaching Hospital. And it will also identify factors associated with such DTPs, and also will facilitate early identification of high-risk patients, enabling targeted medication review and individualized pharmaceutical care interventions. The last but not the least is that assessing the acceptability of pharmacist intervention will provide an important measure of the effectiveness of clinical pharmacy services and would also strengthen the interprofessional collaboration between pharmacists and other healthcare providers in optimizing medication use. So aim and objective. The aim of the study was to assess predictors of DTPs and acceptability of pharmacist interventions in the medical ward of Ahmadu Bello University Teaching Hospital. And of course, the objectives were to determine the predictors of the DTPs, as well as to assess the acceptability of pharmacist intervention among such hospitalized patients in the medical wards of ABUTH. So methods. The study area, like I said earlier, it's the medical ward of Ahmadu Bello University Teaching Hospital. And the study design, it was a prospective interventional study with 16 weeks follow-up. And the study population include all hospitalized patients in the medical ward receiving medications as at the time the study was conducted. And we had an ethical clearance before the commencement of the study. And this is the ethical clearance certificate number. So data collection instruments. One, we used the pharmaceutical care documentation form, which is a form developed by the Department of Pharmaceutical Services of the study facility for provision of their routine pharmaceutical care activities. And that was used with permission. And then we also used the PCNE classification of drug-related problems version 9.01, which is the latest version. And then we used the particular section that evaluates intervention of pharmacist proposals. Now, data collection procedure. Data was collected over 4 months period from February to May 2024 after ethical approval was granted. And then 90 patients were included. And then we used the structured pharmaceutical care documentation form to collect their subjective, objective data. And such data were evaluated for DTP and during therapeutic and also clinical ward runs. We also use binary logistic regression to evaluate the predictors of DTPs while setting statistical significance at p less than 0.05. And then acceptance of pharmacist interventions were assessed using frequencies and percentages. So this is the result. This table 1 shows socio-demographic characteristics of the patients in the medical ward, where we can see that most of the study participants were male.
Break in transmission.
And then most of them have between 45. Hello, sir. Okay, sir. All right, sir. So sorry for the little hitch. So we have number of medications greater than 5 to be a statistically significant predictor of DTP with exponential B of 7.66 and a p-value of 0.001, implying that patient
Time is running down. 3 minutes more.
Okay, sir. All right, sir. Okay, are we together?
We can't even see the slide.
All right.
It's virtual, people are giving us the
Are the slides visible now?
title, you can see only the title page.
Okay, is the slide moving, please? Hello, sir. Hello.
Stop sharing your slide and reshare again. Stop sharing your screen.
Okay, sir.
Yeah. Then share
Okay,
again.
sir. Okay, sir.
Okay, while we are waiting for him to share his slide, we have on the virtual attendance this morning our mother, grandmother, great-grandmother of pharmacy, Professor Cecilia Guilo, OON. Let's celebrate Mama.
God bless all of
Our
you. Well
former
done. We appreciate
president
you.
of WAPC, former dean of pharmacy, University of Lagos, and she's the first vice president of Nigeria Academy of Pharmacy. Please, let's celebrate Mama. You're welcome, Mommy. Also on the
Thank you very
virtual
much. Thank you. God bless you all.
participant, we have our former zonal coordinator of Kogi Zone, Pharmacist Susan Ayetoro. She's also on the call. We want to welcome all our participants online. Thank you for joining us this morning.
All right, may I continue? Hello, may I continue? Hello?
Okay.
All right. So,
is it ready?
Yes, I'm ready.
Your slide is not showing.
Okay.
Your slide is not showing.
It's not showing?
No, it's not showing. Dr. Bello, I think you should share from here.
Okay, is there a need for me to stop sharing and reshare again?
Okay, it's showing now.
Okay, all right. So we have number of medications greater than 5, that is polypharmacy, to be a statistically significant predictor of DTPs with a p-value of p equals to 0.001. And then this shows that patients with polypharmacy are 7.66 times more likely to develop drug therapy problems than patients with fewer medications, less than 5. And this is congruent with the findings of Pellegrino et al. 2029 and McConnell et al. 2018 and Nereo et al. 2024. In fact, This particular finding is congruent with most of what global literature reports as far as polypharmacy is concerned. We can see even the recent presenter has also identified polypharmacy as a significant predictor of patients coming back for readmission due to cardiovascular diseases. So the next slide is acceptance of pharmacist intervention. And then here we have a very significant percentage of the interventions being accepted and fully implemented by the healthcare provider, or let me say by the prescriber or the patient. So we have 86.7% of all the interventions that were proposed being fully accepted and implemented. And then this shows a very high level of intervention of acceptance of pharmacist intervention in the study facility. And this is also similar to what the findings of Park et al. 2015, Panita et al. 2023, and Ahmed et al. 2024 also got, which also who got also 84.1, 98.8, and 97.4 acceptance rates for their interventions, respectively. So, summary of the findings. Number of medications greater than 5 was a statistically significant of DTPs, and also the study showed a very high acceptance rate for pharmacist intervention. So in conclusion, polypharmacy significantly increased the likelihood of DTPs, while pharmacist interventions demonstrated high acceptability, reflecting strong interprofessional collaboration between pharmacists and other members of the healthcare team. So targeted pharmaceutical care and enhanced monitoring for patients receiving multiple medicines may reduce DTP burden and improve patients' outcomes. Recommendations. Hospitals should fully integrate and engage clinical pharmacists more actively into medical ward rounds and therapeutic decisions. And regular medications review by pharmacists should be emphasized, especially for patients on multiple medications, as polypharmacy was identified to be a statistically significant predictor of DTPs. These are some of the references we used, and thank you very much for listening.
Thank you so much, the presenter. Thank you. Thank you. I know you used our time. I don't know how we're going to penalize you. Okay.
I'm sorry, sir.
Questions, please. Questions? Okay. I don't know why the ladies are not asking questions in this hall. What is the problem? Is it because of code?
Thank you, presenter. First, I want to commend the design. The prospective design is very appropriate. The 16 weeks follow-up period is also very appropriate to my mind. But my question is, though you presented the result of the acceptability, the acceptance, I would like to know details of how you assessed this acceptance, how you assessed it, the domains of the acceptance that performed better than the other. You just gave us the whole performance of the acceptance. Secondly, the finding that it is only polypharmacy that was significant as a predictor of drug therapy problems. Are you satisfied with that? That is just polypharmacy? It's already established in literature everywhere that polypharmacy is significant, but all the other domains performed poorly in your study. Do you think it's only polypharmacy that actually affects, predicts drug therapy problem in ABU Zaria? Thank you.
Okay. Actually, the details for the acceptance, like you see, the PCNE version for drug. Yes?
Go ahead.
Okay. The PCNE version for drug-related problems also had a kind of a breakdown of intervention acceptance. And then what we have first, as you can see, is when the intervention is accepted and fully implemented. So this is a situation whereby the pharmacists provide an intervention, and then the doctors or the prescribers there and then accept the intervention and then implement it into fully implement what has been recommended. So there are other categories of interventions, like when they are partially implemented, or when they are accepted but they are not implemented. And then, of course, sometimes you can see intervention not accepted at all also has its own, what do you call it, domain. And then most of what we have here is it's when the intervention was fully accepted and implemented, and then followed by intervention accepted implementation with an unknown implementation status. And this could be as a result of maybe delayed implementation. You know, what we have seen is that sometimes an intervention will be raised, it will be accepted, but then the implementation might be scheduled for a future action. Sometimes interventions might require approval by a senior consultant who is not domiciled in the unit, because we do send, you see, consult will be sent to a patient is in cardiology, for instance, and consult will be sent to a consultant in neurology. So such an intervention might be accepted, but its implementation is pending implementation by other consultants from other units. So we may not actually ascertain the status of such kind of interventions, whether they have been fully implemented or not. So what the study reported is intervention. Most of what the study reported or found was interventions that have been fully accepted and implemented. And then you also talked about polypharmacy. Actually, like I said, the general literature have identified polypharmacy as what do you call it, as a as a predictor of disease. We also have, in my own opinion, other factors like comorbidities.
You are making another presentation. Thank you.
I'm sorry.
Thank you so much.
Comorbidity is also a predictor of DTP, but then the more the number of comorbidities, the more the number of medications that
representing. It's okay now. It's okay. Thank you so much.
Thank you so much.
Let's clap for him.
All right, sir.
Do we have a physical person, please? Okay, one last virtual. Okay. Let's bankroll the virtuals. Now finish the physical.
So while we are still waiting for the next slide to be shared, let me quickly recognize online the virtual participants. We have the former director, PVPMS NAFDAC, pharmacist Adeline Osakwe. She's online. Please, let's celebrate her. Also online is our industrialist, pharmacist Kamar Abu Said, is the secretary, Faculty of Drug Production and Quality Assurance. Please, let's celebrate the amiable industrialist. We also have the head of the Department of Pharmacology, Faculty of Pharmaceutical Sciences, University of Ilorin, Dr. Atunwa is online. Pharmacist Rukayat Muhammad Adamu from Nasarawa State, we welcome and recognize you. Please, somebody misplaced umbrella is here. And then registration continues tomorrow, 8 to 10 a.m. before the opening ceremony. Thank you. Next presentation.
Thomas, are you online?
Yes, sir.
Yes, you can start. Click on the slideshow to make it a full screen and go ahead.
Can you hear me, sir?
We can hear you.
Can you hear me?
Yes, we can hear you.
Yeah, good day.
Put it on
Good day,
slideshow.
everyone.
Put it on slideshow, please.
My name is Musa Adojibin from the Department of Public Health, National Open University, Lagos, Nigeria. I'm here to present the aspect of the topic awareness and rate of utilization of NAFDAC Mobile Authentication Service, MAS, among the health workers and consumers. A case study of Lagos Mainland Local Government Area, Lagos State, Nigeria, with abstract number WAPCP/0826.
We barely hear you. Amplify your voice.
Can you hear me?
Yes, better now.
Introduction. The NAFDAC Mobile Authentication Service is a security initiative introduced to tackle the menace of fake and counterfeit drugs in Nigeria. It allows consumers and health workers to verify medicine authenticity using a scratch-off code via SMS. It makes use of mobile-based technology to enable verification at the point of purchase using mobile phones. Assessing awareness and use of MAS among health workers and consumers within Lagos Mainland, Lagos Government Area provide valuable evidence for targeted intervention and policy reinforcement. Objective: to evaluate the level of awareness and rate of utilization of NAFDAC MAS and identify the challenges and risk factors associated with its utilization. Methodology: the study is a descriptive cross-sectional study, was conducted among 500 health workers and consumers, selected using Cochrane 1977 single population proportion formula. Data on socio-demographic characteristics, awareness, knowledge, source of information, and utilization of MAS were collected using a structured questionnaire for a period of 4 months. Descriptive statistics, frequency and percentage, and impression statistics, chi-square tests were performed using IBM SPSS version 26, with statistical significance set at p less than 0.05. Ethical approval was obtained from Lagos University Teaching Hospital Health Research Ethics Committee. Results: the overall result shows that 62% of the respondents, that is 310 out of the 500, were aware of MAS, while 52% had utilized the service. Utilization was higher among consumers at 66.9% than health workers. Friends, pharmacists, and social media were the major sources of information. Although 31% know how to use MAS, they have never used it, while only 10.6% reported always using it. The major barriers to the utilization of the MAS
include difficulty understanding on how to use the service, low awareness, poor network connectivity. Utilization of masks shows a statistically significant positive association with awareness. Being a health worker, age 31 to 40 years, tertiary education, and being married show the significant positive association. This is the table that shows the usage of masks. When you look at the pattern, you can see the health workers that utilize masks fall 106, while the consumers fall at 149. Rate of utilization. This signifies that despite the fact that most of the participants know how to use mobile authentication systems, but the rate of utilization was very low. This is supported by Adequate et al. 2021. Research showed that although 65% of respondents were aware of masks, only 20% actually use it, showing a wide gap between knowledge and utilization. This is the table showing the barriers and recommendations. Difficulty in understanding how to use masks. The recommendations say it should educate people on the use of masks. There is a low awareness, which the agency or the government is responsible for to create more community awareness on the mask. Poor network connectivity, that one has to be augmented with stable network. In conclusion, despite moderate awareness, utilization of masks remains suboptimal. Strengthening public awareness and addressing user-related and technical barriers will improve the adoption of masks in medicine authentication. Thank you all for listening.
Thank you so much for the presentation. What I observe in your slide is that they are they're double-weighted. It looks clumsy, and at times some of the slides are not the same. There's some multiple colored layered slides presentation. Clarity has a lot of issue. Then when you made mention of health workers, your emphasis, can you hear me? Presenter,
I can hear
me?
you.
When you made mention of health workers, I saw only pharmacists. Can you hear me?
No, the health workers comprise of pharmacists, doctors, and
But
anybody that is involved.
Hold on, please. That was where you said pharmacists 20%. Then consumers and others. If you are talking about health workers, pharmacists 20%, social media, because you pointed health workers. In health workers, there are triage, the tripartite core health workers, physicians, pharmacists, and nurses. Even if you don't want to mention others, put it others, at least those three will come out. Physicians, nurses, and pharmacists are the tripartite core. Anywhere in the world. I'm not saying others are not important. They are the tripartite core. You have to mention, or you keep pharmacists among the health workers so that the research will be consistent. Any other person?
Okay, sir. Noted.
Okay.
So, well done, presenter. The title tells us that there are two major constructs in your study, which is awareness and utilization. But in the presentation, you brought in another construct, which is completely different from awareness, which is knowledge. Are you interchanging knowledge with awareness in this presentation? Thank you. Or do you think they're the same? Thank you.
Next person.
No.
Oh, it is
No,
affecting them. That means, Dr. Naraka, please. We need hot tea here. Answer the presenter. There are two questions before you.
No, sir. I'm not interchanging. I'm not interchanging the two.
Okay, go ahead, sir.
Yes.
As he's preparing to answer the last two questions, any physical presenter, please. We have 4 remaining. Please get ready. Are you here? If it's okay.
Hello, sir. Can I get the questions again?
He said what?
The
Can
question,
you get
the
what?
last two questions. Yeah. Can I get it? Can you?
The questions.
Can you say it again? Yes, sir.
He said we should repeat the questions. That means
yes.
you want Jesus Christ to come again, Abi?
Yes.
Okay. Dr. Funsho, they say you should repeat, paraphrase yourself. I hope you can open your ears. If you have a problem, we look for
yes, sir.
ENT pharmacist consultant.
Okay, the question is just very straightforward. Okay, you also introduced knowledge when you are presenting the results, but your title said awareness and utilization. So my question is, are you interchanging awareness for knowledge or knowledge for awareness? Thank you.
I hope you can
I'm not interchanging.
Now. Did you get him?
Yes. I'm not. Yes, I get him. I'm not interchanging. What I mean.
Okay, you are not interchanging. Thank you. Say it's not interchanging, yes. Dr. Funsho. Well, they need physical presenter. The next presenter. No, these are our presenters. Have they run away? Okay, one is outside. Come now, please. We're supposed to have 4 remaining. We have 8 oral. Yes, 8, and we've done 4. Remaining 4. Dr. Pella, are you doing? Okay, another online again. Okay. No, if they want, all of them want to do online, let them do. No problem. If they are finding it Herculean to come to Lagos, let all of them speak online. No problem.
Please, if you misplaced your umbrella, it's right here beside me. I'm not taking it home. It will stay in this hall. So please make sure you collect it before you go. Okay. I also want to introduce to us among the virtual participants, our former HABS National Chairperson, Pharmacist Scholastica Lan. Please let's welcome her warmly. She's on the call this morning. Madam, we recognize you and we thank you for joining us. Are we ready? Are you physical? Okay. Yes. Okay. You are Godwin. Okay.
Okay. Good afternoon, everybody. I'm from Godwin Emebina. So this presentation is about the feasibility of using quantum data tools in community pharmacies in Lagos State. It was a study that was carried out to ascertain how this technological device can be useful in improving performance management in community pharmacies. So I'll be going through the following subheadings. Okay, so talking about quantum data tools, I'm concentrating on two specific devices, which is the quantum weak resonance magnetic analyzer and the 9D nonlinear system. So these are basically informational devices and they are non-invasive. So I wanted to see if they will be of any benefit to community pharmacies. So there has been no known research about the awareness of community pharmacists on quantum data tools, and there are scientific validity concerns. Also, there is no regulatory guidance yet about these devices. So therefore, there was a need to look at the feasibility of the use of these devices. So the general objective was to ascertain the feasibility, and then there were 3 research questions, which included the potential effects of these tools on performance management in community pharmacies, and then to see how the integration of these tools can influence workflow efficiency, stock management, and patient care, and to ascertain the level of awareness, knowledge, and attitudes of pharmacists regarding these tools. So 2 basic theories that underpin this study are the diffusion of innovations theory and the technology organization environment framework. So it was actually a descriptive cross-sectional study, and it was carried out in peri-urban and urban regions of Lagos State. So licensed community pharmacies were the respondents, and the sample size was 110 samples were taken, and there was a return of 100 samples. So validated structured questionnaires were used for the study. So at the end of the study, there was a 90.91% response rate, and 67% of the respondents were in urban locations. 88% were independent pharmacies, and 12% were chain pharmacies. And more than those that had more than 4 years of experience were 69% of the respondents. So, with regard to the awareness and exposure to quantum data tools, we discovered that most people got to know about quantum data tools through vendor demonstrations. So, followed by there was a low percentage that were not aware about quantum data tools. So, with regard to the knowledge of quantum data tools, 68% correctly identified the quantum weak resonant magnetic analyzer, while 81% identified the 9D NLS, indicating uneven familiarity. So 23% incorrectly believed quantum data tools could replace conventional diagnostics. So with regard to the perceived usefulness of quantum data tools, a good number recognize the usefulness of quantum data tools, that it will help them in their clinical counseling, inventory control, it will streamline workflow, it will also help to satisfy their patients better. With regard to readiness for adoption, there were certain concerns with respect to costs and clinical validity, regulatory approval, and peer recommendations. So these are the perceived barriers to the adoption of quantum data tools. So this is the summary of the hypothesis testing. So 74% of awareness was driven by vendor channels, and this mirrors the diffusion of innovation theory. The knowledge, there's a knowledge gap, and the knowledge gap depicts that the adoption of quantum data tools has a conditional feasibility. The highest mean construct was seen for perceived usefulness, and indicates that pharmacists see quantum data tools as very relevant to their performance in the community settings. So, in conclusion, quantum data tools in Lagos State is the adoption of quantum data tools is conditionally feasible. So, quantum data tools have the potential to enhance pharmacy performance, workflow, stock management. So these are the recommendations. The recommendations are that regulatory authorities should have official memos on permissible quantum data tool use as adjuncts, not diagnostic tools. And then there should be a mandate for initial validation. Academic and training institutions can introduce elective modules on digital health, health informatics, and health technology assessments. And community pharmacy owners should conduct due diligence on cost, staff competency, and workflow integration. And it shouldn't be presented as diagnostic devices. And then future researchers should conduct multi-stage longitudinal studies on quantum data tool perception and adoption. There should be design of comparative studies assessing the output from quantum data tools in relation to gold standard diagnostics, and there should be a cost benefit and health economic analysis on the deployment of these tools. So the limitations to this study are that it was carried out in Lagos State and is a cross-sectional design, and then like every other studies, there's an element of bias since in the self-assessment, and then there's need to carry out more clinical validation on the use of these devices. These were the references. Thank you very much for your audience.
Questions? Okay. I know our pioneer chapter chairman or our former chairman would like that because this is to community pharmacy, right?
Yes.
Okay. Let me give it to Dr. Nya, a community pharmacist, to bleed you small. Have the mic, sir.
Thank you very much. Please, I'm not bleeding anybody. Yeah, thank you, presenter, for the work that you presented. I tend to a little bit get confused with the title that you chose and what you eventually presented. You're talking about quantum data, right? And data is the information we get from a device, right? But the other challenge we're having is that you're also talking about the quantum device itself. So are we talking about adoption of the quantum device or the data arising from the usage of the quantum device? These are two different areas I want you to look at. Secondly, I also want to use this as a note of caution. If what you are talking about is also what I think that I've experienced with some people in my practice, where people will go to some of these quantum-based devices that will literally diagnose your condition from head to toe, and they come back with a result on a slip, you know what I mean, to you in your community practice. And when you look at the result, some of them will show you. You'll be wondering whether the person showing you the result is the person that is still alive, or whether the person is in the grave and they send the results. I've come across this. I don't know how many of you that would have come across that. So let us also be very careful with regards to some of these unvalidated devices, because promoting them may create more harm. I'm not saying that POCTs are not good. That's my specialty. That's my area. You know it. But we must also ensure that whatever we are using is validated and that the results coming out from them are accurate. But my specific question is, are you talking about the quantum device itself? Or are you talking about the data that is coming from the usage of those devices? Thank you very much.
Okay. I'm talking about the devices themselves, but definitely the devices will generate data that will help to improve our practice.
Thank you very much. I'm Dr. Musa Yakubu from Kaduna State University. Part of the question I want to ask, Oga has asked this, but in addition to that, I want to know how did you determine your sample size? Was it just a convenient sampling? Because you say 100 response out of 100 is 110. Did you just go to any pharmacy you can get, or there's a formula you use, or you just select pharmacy across Lagos State? I would like to know, please. Thank you.
Okay, I actually used Yamani's formula. However, there was a 10% error factor. So Yamani's formula was used, and the actual number of community pharmacists in Lagos State as at 2025, which was 1,914, was used as the total population from which the sample was taken.
Okay. Thank you. Your methodology, you talked about the feasibility, and on one of your slides, you showed some theories. So I assumed it was going to be implementation science. But in your results, I didn't see the implementation science coming out. Even in your methods, you said it was cross-sectional. So I was wondering, why did you use those theories?
Okay. The theories were actually talking about how a new technology can be infused into a society, how a group of people can adopt a new technology. So this is not the essence of the study. Was not to to give a go ahead to use the devices, but to test to see the perception and to know the feasibility among pharmacists. And the study is actually supposed to underpin future studies whereby further tests will be carried out in comparison with orthodox devices, and see if there is any good thing that can come out from these devices that we can adopt.
You finished? Okay. Any other question, right? So we can free him to go now. Yes. Take a bow and go.
Thank you.
Okay, that is the 5th presenter. Still remaining 3. Okay, one online. Is the online person ready? Okay. I hope this person is in this hall. Evaluation of the phytochemical, toxicological, anti-lithiasis activities of methanol extract of Phyllanthus amaris. I hope he's here. I'm so much interested in this topic. If the person is not here, he should come here.
Okay, so while we are waiting for the online presenter, I think she just walked out now. Pharmacist Oluwatimileyin. She's former director of pharmaceutical services, FMC Owo. She was AHAB chairman of Owo, right? Which state is that? Ondo State, yes. She was former chairman of AHAB, Ondo State. She has been the zonal coordinator in Akure area. So we want to welcome her. And please just give her a round of applause in absentia. When she comes in again, then we'll do it again. Dr. Bello? Okay.
Please, can you hear me?
Yes, we can.
Can you hear me, please?
We can hear you.
Okay. Good morning. Please, can you see my slides? Can you see my slides?
We can see your slides now. Please, can you put it on slideshow?
Okay. Thank you. Good morning, everyone. It's already afternoon now. Good afternoon. Senior colleagues, fellow colleagues. Yes, I'm Eponiramika. I'm at the University Teaching Hospital, presenting this morning on the topic strengthening antimicrobial.
Raise your voice, please.
Okay.
Please, are you a broadcaster?
Topic Can you hear me now? Hello, please, can you hear me now?
Go closer to your mic.
Yeah, please, can you hear me now?
Better.
Yeah, better.
Okay. Thank you very much. Yes, good afternoon, colleagues, senior colleagues, junior colleagues. I'm Ebun Boniri Alemika, presenting on the topic strengthening antimicrobial stewardship through expansion of consultant pharmacies. Clinical roles in the intensive care units of Nigerian Tertiary Hospital. And so, these antimicrobial resistance in intensive care units is a major concern in Nigeria due to high empirical antibiotic use. And the World Health Organization recognizes AMR as one of the top 10 global public health threats. We all know that, particularly in Nigeria, it's it's been a terrible menace in which an individual could just go ask for anywhere and just get a capsule of Ampiclox, probably because they have a boil or something. The ICU is the core epicenter for selection and spread of multi-drug resistant phenotypes. According to Child et al. 2025, consultant pharmacists are advanced clinical practitioners with a specialized expertise in complex pharmacotherapy, medication optimization. Consultant pharmacists are gradually becoming recognized, like I had my senior colleague, Pharmacist Ruth, present earlier, and we're knowing that we're being recognized as key members of antimicrobial stewardship. Also, a senior colleague too, Pharmacist Bukola, who is our keynote speaker for tomorrow, all there be represented and being recognized for their clinical roles, although these roles are being unutilized in our teaching in our hospitals in Nigeria. The objective of this study is to evaluate antibiotic prescribing patterns and antimicrobial resistant profiles in the ICU of Ahmadu Bello University Teaching Hospital and determine how these findings could support the experiment. Yeah, please, can you hear me? Using the ICU records from January 2024 to 2025, and it was a total sample size that was used, and by the time the inclusion and the exclusion criteria were taken into cognizance, a total of 168 patients were reviewed, including 110 culture positive isolates. An ethical clearance was also obtained from appropriate authorities. The antibiotic utilization pattern and antimicrobial susceptibility were assessed using the CLSI guided. Yes,
we can't see your slides.
You are better a correspondent than a pharmacist.
Yes.
Okay.
All these TVC people, are you here? Please see your candidate.
Sorry, it was just a little network. Please, can you see it now?
No. Okay. So now put it in slideshow. Okay.
So the antibiotic utilization pattern and antimicrobial susceptibility were assessed. Data was analyzed using descriptive statistics, chi-square test, and significant at P less than 0.05.
Pharmacist Ebun, please hold on.
The results showed that
we are not connecting with your presentation. We can see the slide, but you are not
predominant.
Is it network?
Yes.
He's asking you, is it the problem
kind
coming
of
from the barber?
I'm at the results now.
Or the materials for barbing? Let us know. Okay, network. But when you were speaking so fast, there was no problem with network.
She's speaking so fast.
It's better you go to US. So in Nigeria, you speak so that we can hear you.
Sorry. Okay, please, can you hear me now? I'm on results slide.
Speak like that at that rate.
Okay, thank you very much, ma'am. So gram-negative organisms predominantly seen, with E. coli having a 44.5%. We had Klebsiella at 17.3% being the most. These three were the most frequently isolated pathogens. And when it came to the most prescribed antibiotics, we're able to see that ceftriaxone had 56.7%, metronidazole 64%. This is actually indicating that we have substantial empirical therapy. Meropenem demonstrated the highest susceptibility rates, and this is actually one of our reserve drugs, whereas ciprofloxacin and ceftriaxone showed lower susceptibility, approximately 66%. So meropenem retained 96.4% to 3 gram-negative general signal. We have ACRE, CRPA emergence. 34.5% of the patients received no culture-guided therapy. This is definitely indicating that we a critical AMS gap driving resistant clone expansion. Here is the graphical representation. There we could see the other antibiotics and the percentages in which they came in. These were the predominantly prescribed antibiotics. And then we have the distribution of the bacterial isolates. We can see them there. The first three, like I earlier said, being E. coli, Staph, Klebsiella. Then we have the others down there. And then there was a significant association between antibiotic class and then the bacterial response. This highlights opportunities definitely for consultant pharmacists to strengthen antimicrobial stewardship. That is to say that we have a gap when it comes to our antimicrobial stewardship, and this is a point for we consultant pharmacists to step in fully. And we could do this through more prescription review, culture-guided de-escalation. This was one I could actually even intercept in personally over the weekend, where we had a child, an infection from a baby coming, and the first thing that the doctor was actually going to prescribe there was meropenem. Not until my interception, I was like, we don't have to go as far as meropenem. And luckily, the MCS, the parents had actually done an MCS, although they didn't want to take that into consideration since it wasn't done in the facility. But the result shows that even as low as gentamicin was actually even susceptible. So I could just imagine where the doctor wanted to go as high as meropenem. Gentamicin was actually even susceptible for that particular child. So these are instances in which we could actually press in to come in much more. We could actually also contribute in antibiogram development, antimicrobial use surveillance, multidisciplinary clinical decision-making, and policy implementation. High empirical broad spectrum antibiotic use and emerging resistant patterns in the ICU therefore underscores the need to expand and for us to actually come in much more. So these are my references, and I just want to use this to also talk as impressed onto other colleagues to see that there's actually a gap and could actually do much more if we press in there. Thank you very much.
Thank you so much, journalist.
Hello, please, can you hear me?
Journalist, pharmacist. Okay.
Hello.
Can you hear me?
Yes.
Our section is because there is another section coming up.
Hello?
We have to be very fast so that we'll not crop into the section of other distinct. Can you hear me, the presenter? The journalist, can you hear me? Journalist, pharmacist. I want to ask you a question. But the person can't talk again. Have you disappeared?
No, I'm here, sir.
Okay.
My screen, the network.
You said meropenem have the highest susceptibility rate.
Yes.
Is it meropenem has the highest susceptibility rate or meropenem has the highest resistant rate? I don't know whether you can get me. Are you sure you're not making a mistake? It's supposed to be resistant rate, not susceptible. Meropenem is the one killing the microorganism. It should be resistant.
Yes.
So you have to paraphrase your statement, your grammar there. So because it's confusing. And I know meropenem equally have a beta-lactam rank, in as much as other ones have. And it destroys more of gram-positive microorganism. Gram-positive more than gram-negative is just slim. It's just slim because it has more potentials to intercalate with teichoic acid of gram-positive microorganism. And that's why it destroys Staphylococcus aureus and albus much better. Now, if that thing works, how is it not giving us 98% destruction of Klebsiella species and this Escherichia coli? Are you sure? I don't want to discredit this study, but are you sure there wasn't anything during the course of this study, please? That is my question.
Okay, so actually, what was done here, I said it remains. What I said was that it remains the highest. It retains the highest.
Bring down your
efficacy.
voice, as in speak slowly and amplify. Okay, woman want to ask. Okay, that is good. Let me give Oga the back before the woman. Please transfer.
Thank you very much. Good afternoon, dear colleagues. I think what the presenter was, thank you for your presentation. What she was referring to when she talked about meropenem having the highest susceptibility rate simply means that most of the organisms were susceptible to this meropenem in terms of the efficacy of the meropenem because it has not been abused in that hospital. So most of the organisms isolated were sensitive, were susceptible to the efficacy of meropenem. So that's the susceptibility rate of meropenem. I think she was right. Now, my question is, I wanted to find out what happened because the way she was talking about empirical use of antibiotics in the ICU, and when she mentioned meropenem as well, she said that there was a lab result that came out and they found out the patient should have even used gentamicin. So what did they do in that case? Were they able to convince the doctor to change the antibiotics to the gentamicin, or did the doctor continue with the meropenem? Because the truth of the matter is that we pharmacists must guard these antibiotics as much as we can. Because if we start having resistance to meropenem, then where do we go? And again, I want to find out if the AWARE classification, whether they are using it in her institution where she's working. Because that's one thing we must insist on. So that it's not all doctors that should prescribe meropenem. Meropenem is actually the reserved class of the AWARE classification. So it should be the last resort. So that. Thank you very much.
Okay, thank you, sir. Can I respond to that? Can I respond?
Go ahead.
Okay,
Go ahead,
thank
we
you
don't
very
have
much.
time.
Yes, thank you for the clarification. Thank you for the clarification on the susceptibility. Yes, we're using the AWARE class. And for the issue of the meropenem, yes, I was able to intercept. We're able to intercept on that. And meropenem was stopped and gentamicin was actually part of what they continued. The funny thing was meropenem, alongside even with the gentamicin, was actually what was prescribed. So when we could see that gentamicin could actually go down, meropenem was knocked off the list. Thank you very much.
Okay.
We are using the AWARE list.
Hello, Pharmacy Sebun. Thank you very much for
yes,
your
ma, I can hear you, ma.
Okay, thank you very much for your presentation. The first question I want to ask is under your introduction. Bullet point 2, you quoted WHO as placing as 10, the top 10 public health, but you did not cite it. So that is an important information you're supposed to cite. That is the year or whatever that WHO made that statement, so that we can go back and look at it. That is one.
Secondly, you mentioned that meropenem is under reserve in the AWARE classification of antibiotics. And if it is under reserve, you know there have to be pre-authorization from selected authority. Now, did you check the patient's folder? Because I saw you bringing out some results of the patient. You should be able to know. Did you check if there is pre-authorization? Because as a pharmacist, when we carry out some specific research, is because we want to make intervention. And from the outcome of your research, you should be able to recommend some intervention and the gap that needed to be filled to the authority. So did you check if there is pre-authorization? If no pre-authorization, what did you do? Thank you very much. I hope you got my questions.
Okay, thank you. Yes, ma'am.
I am not the one that presented. Okay, another woman. That is good. If all the women want to take, no problem. I'll give it to them to speak.
Thank you so much. Good afternoon, everyone. Good afternoon, Dr. Ebon. Thank you for this wonderful presentation. I got interested because I work in the intensive care unit in my facility, and I can really understand what you are saying, everything that you really presented here today. Most of the issues we have in the intensive care unit is that most of the time the patients come in not being stable. Some of them are even, unconscious. And then when they come in like that, the physicians, they come in, they kind of panic, and they want to start with a medication that is, they don't want to hear if there's an issue. And that's why they go very, very high. So we have a lot of work to do. In the intensive care unit, antimicrobial stewardship, we do a lot of checking, because apart from the fact that most of the patients, they come in, there's high risk medication, and they take a lot of drugs because some of them already have an existing condition before they even got into that admission, probably traumatic brain injury. And the patient will be treating other things. And so you see a lot of medications being pumped into that particular patient. It's even worse for the pediatrics. So what we do when they come in like that, when they write, we stand by and do a lot of review. So I can really understand what you have done and this work that you have done. And I really wish, like you have also mentioned, like somebody pointed out, if this intervention was kind of positive, because that is what actually matters. If the physicians was told, and then this there was a change, and to also maintain it, because apart from the costs, it can also lead to resistance. Thank you for this. You're wonderful.
Thank you so much, Dr. Timmy. No, it's a PRO.
Thank you very much.
It's a PRO. These PRO people, they talk long at times. We have, this section is already ending, but it's unfortunate we cannot see two authors that are supposed to speak to us this afternoon. I don't know, it's like they decided to decline. Contraceptive awareness attitude utilization among female health science students in a conservative setting. And the one that worked on nephrolithiasis. Very interesting topics, and they decided to sit behind, but there is no problem. We will catch you next time. If you keep running, the next conference, we're going to catch you. Because he did a very nice study, and they are deciding to run away, to elope. This one is not really of a man looping with a woman. You are eloping with what you gave to us. And we are going to present you before the tribunal judiciary to tackle you for eloping with our topics. Thank you, the fellows in the house and the appointed consultant. We are almost running up this section.
So,
I am going to hand over the... Please, thank you. You have spoken enough, journalist, consultant, pharmacist. Thank you so much. Thank you. We don't have time again. I will be handing over this microphone to the CPC chairman so that he can continue while the assessors will go to the other side and assess the posters. Then when they finish, we'll call it a day. So, ladies and gentlemen, thank you for the support. Thank you for the participation. It has been really a funding section and a very wonderful one. So, Dr. Danraka, okay, you,
Yes, while we're
the director of ceremony.
welcoming Dr. Danraka, I'm very privileged this afternoon to welcome into our midst the Pro-Chancellor and Chairman Governing Council, Benedict University, Okada, in the person of Professor Ahmed T. Mora. You can see our father is still looking like under 16. Welcome, sir. We also have in our midst Dr. Okafor, former director in charge of the Pharmacy Council of Nigeria, Lagos Zonal Office. Wow, 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 wow. You are welcome, ma. Also in our midst this afternoon, we have the representative of APS National Chairman, who is also in her own person, the Zonal Vice Chairman Southwest, pharmacist Folarin Ololade Mojisola. Yes, she's up there. Please, madam, wave to us. We thank you for coming. We also have here in our midst this afternoon the Director, Central Medical Stores, Lagos State, Pharmacist Margaret Adedapo. Pharmacist Margaret Adedapo. You are very much welcome. So over to you, Dr. Danraka.
Thank you very much. Yes, please go ahead. So please, the poster presenters should step out so that the assessors can review their presentations. Indeed, we have up to 12 poster presenters and 8 are already on display. The posters will be available till tomorrow, but right now is actually the assessment that is taking place. So please, all poster presenters should kindly step out so that the assessors can engage with them. We are slightly behind schedule, but we'll catch up by God's grace. The session we are entering is combined with lunch, so it's walking lunch. They are serving the lunch. Please just take it and quietly. You can collect your lunch and stretch a little before we start the next session. The next session is the capacity building workshop that is advertised. I will invite the chapter secretary, Dr. Ebele Onwuchuluba, who will chair this session for us. Okay. Please. Okay, Okay, so that's fine. So please, I beg your pardon. I will call on the vice chairman of the chapter, in person of pharmacist Dr. Ruth Ajayi, to chair this workshop session. Please, ma, come over. We will support you. Just come over. Then to join her will be the technical resource persons. I will start with our own Dr. Sikiru O. Usman. Dr. Sikiru O. Usman, is he around? Yes. So he's ably represented by our own immediate past Secretary General, Professor Ibrahim Oriagba. So, Prof, please come over to the high table. Yes. I'm also recognizing him as he's walking in, our immediate past Chairman, Secretary General of the WAPCP. Sir, please come to the high table. The next person is Mr. Matthew O. Oluwani. Mr. Matthew, please come up. He's our resource person for today, one of our resource persons for today. Please come up to the high table. At the right time, we'll say a brief about you so that the participants can get to know the wealth of experience of our... Professor Oriagba, please come over. So ICT, please, we are having the first technical session. No, don't worry. Before I call you, let's technical. Before I hand over to the chairman of the session, I want to say that the first technical session is titled Leveraging Artificial Intelligence for Excellence in Pharmacy Practice and Research, Tools, Techniques, and Applications Across Specialties. The specialties is missing in our programs. Please, let's just correct it. We should add across specialties. The person that is leading us in that, while we wait for the chairman of session, let me just read his brief citation and our abridged version. Okay, I have it here. Please, our first resource person, kindly stand while I just briefly introduce you, and using that to wait for the chairman of session. Matthew Oluwani is an architect and AI artificial intelligence literacy advocate with digital transformation architect and AI literacy advocate with extensive experience helping professionals and organizations harness emerging technologies to improve service delivery, decision-making, operational efficiency, and stakeholder outcomes across healthcare, academia, and industry. He is particularly passionate about artificial intelligence readiness, digital transformation, cybersecurity resilience, and the future of work, helping professionals and institutions navigate the rapidly evolving technology landscape while maintaining ethical, secure, and human-centered practices. He is the resource person that will take us through this very important topic that will improve our skills and capacity on utilizing AI tools to facilitate pharmacy research and also the works we do across specialties. Thank you for having you. Please, let's give him a round of applause. So I will give the mic to the chairman of sessions for her remark before she yields the floor to him for the session. Thank you.
Good afternoon, dear colleagues. Permit me to align with the existing protocol, welcoming everybody to this afternoon session. SG, sir, you're welcome. At least have to. Oh, okay, it's true. IPSG. You know, it's still written all over you. So you're welcome. So, please, I want every one of us to listen very well. This is going to help us, as we know now that AI is going place in the world. So we have to know what is going on. We have to know how we can make use of it legally, even in our research, in our business, so that we're not going to breach any law. So thank you very much. Let's sit, take your lunch, relax, listen, and learn. So over to you. Thank you
very much. Good afternoon, everybody. Yes, I understand that we'll be taking our lunch at this moment, so it's understandable if response is not coming in. First, as they bring up the PowerPoint of this workshop, I want to appreciate this professional body for coming up with this opportunity to speak with you, then also for deciding to actually have this topic. I understand that a lot of people have what we call technology phobia, and they don't want to walk the path of technologies like this. I remember the first time I was talking, or the first time I spoke about artificial intelligence and how to adopt artificial intelligence at the Obafemi Awolowo University, there was some palpitation. A lot of people, some persons were actually scared and concerned, especially with different information that has come with artificial intelligence. However,
for any organization or for any professional body to take advantage of evolving technology, especially digital transformation technology like artificial intelligence, it's very important we constantly have this kind of workshop, and also we start having discussions along this line. So I'll be speaking on the topic, leveraging artificial intelligence for excellence in pharmacy practice and research. For me, I'm not a pharmacist, but in the last 18 years, I've been working with pharmacists and been trying to provide resources for them, especially at the Obafemi Awolowo University. Now, what are the expected learning outcomes? There are three things I'm going to be focusing on. Number one, we're going to evaluate opportunities for AI integration within different areas of pharmacy practice, because at the end of the day, it's very important for us to realize the fact that there is no sphere of human endeavor that AI would not be integrated into. If it has not been integrated into, that it would not be integrated into. So we're going to be evaluating opportunities for AI integration within different areas of pharmacy practice. Then also, we're going to demonstrate some practical use of AI tool for knowledge discovery, evidence synthesis, then professional productivity. Then also we're going to apply principles of responsible and ethical AI use in healthcare. While this is one of the most important aspects for me as an individual, because one thing I've taken note of is everybody wants to use the technology, but nobody is sitting back to assess the ethics of the technology, the safety behind the technology, and what can we do to ensure that we don't use a technology that eventually, let me use this word, backfire. So that's why it's a very important aspect, and probably at the end of the day, I will be throwing a challenge to this professional body to ensure that there's an AI dimension in areas of responsible ethics, especially when it comes to research and practice in pharmacy. Now, it's very important for us to establish this fact that the future of pharmacy, just like every other profession, just like every other professional body, is AI augmented, not AI replaced. There was a particular period, I think most of last year, the debate has always been, will AI take over our job? Will AI take over some jobs? And sometimes you will see some articles, jobs that are more at risk of being taken over by AI. I remembered listening to I think it was a radiographer. He was sharing his own pain. He's in the US. I shared his video on my page. And he was discussing about a particular AI-driven technology that interprets X-ray better than professionals. And he was one of the top person in his organization then, that any particular X-ray or in that particular category, they bring it to him because there are some things other would miss. He would not miss it. Now, Microsoft launched a particular AI-driven solution in that direction that does better work and brings up better interpretation than he could do. And it was like, it's like I'm losing my job. But at the end of the day, one of the discussions we start having is AI would not take over what you do. One of the direction we're going into is for everything we do to become AI augmented. And that's one of the reasons why we started encouraging people to begin to understand the pathways, to begin to understand how to adopt AI, how to integrate AI into your work, because it's very, very important to take note of these. Now, with respect to our professions, we are going to be exposed to different kind of data, both data we use and data that we generate, and also the knowledge base, especially from our place of training. Most of this would come up. However, it's very important that we establish this fact that no matter any of these that we have talked about, AI would not take over your work. However, when it comes into the AI landscape, into the AI ecosystem, most people don't realize that SMEs, now in the world of AI, when you say SMEs, we mean subject matter experts like you. They have a very strong role to play in the AI ecosystem. there is no way AI can function effectively without subject matter expert. And that's why for every AI project that I get involved in, for every AI project that people that understand what they are doing, once you are setting up the project, the first question they ask you is, who or where are the subject matter experts? Because AI is as good as whatsoever the subject matter expert makes out of it. I was called upon to review a particular checklist for an ethics committee of a university. And one of the reasons they had to call me is they begin to discover that researchers are now introducing AI into their work, and the traditional ethics committee don't have any framework that guide the deployment of AI into our work. And as a result, let me jump ahead, I will come back. As a result, most people don't realize that, especially with generative AI, because that's the most used AI presently, generative AI. Most people don't realize that when you take an information, you put it into AI as a prompt, it goes into a database. And that's why even there's a part of me that is very, very cybersecurity conscious. And that's why I talk this way. When people bring up their data or even data from your research, you need AI to fine-tune it. Once you put it into that AI, it stays in that database even when you already get your result out. And that's one of the reasons we always say that it's very important, even as you as an individual, especially, we try to use generative AI to improve our resume, and you put your own resume into AI to look for you, you have exposed yourself. And one of the things I say is that before you carry out such action, make sure you remove what we call PII, personally identifiable information, away from those data. Because you cannot entrust your data into a third party and expect that there's going to be an absolute protection of your data. We listen to news and we hear of even companies that you respect having data breach. I play around the space, that's why I say I play around the space of interface of cybersecurity, artificial intelligence, and there are platforms that you could see data that has been breached that people go to pay to actually buy. And that's one of the reasons why it's very important for you as a pharmacist, whichever aspect of your specialty, to realize that yes, there is a dimension of AI to your work, but you need to understand some basic ethics that we need to pay attention to. Now, AI is just one technology, but it has multiple applications. I can apply AI in my own way. You can apply AI in your own way. There are a number of applications, and we're going to talk about about some of them. Now, for people in clinical pharmacy, you could use AI application in forms of evidence synthesis and drug information. Presently we have a repository of data in different aspects, pharmacognosy, drug interaction, that all you need to connect to them is what we call API in the world of technology. That at the end of the day, you discover that there are some things, and that's one of the reasons you find out that if you are not using AI, your pace in research and research outcome, you can't match up with somebody using AI. For instance, the person using AI have connection to very massive database of drug-drug interaction, and you decide to go the whole traditional way. By the time you are coming up with your results, the person that uses AI is already publishing. And that's one of the reasons why it's very important to take note of this. Therefore, community pharmacy, those involved in community pharmacy, you can use AI application for patient education, counseling support. And let me say this. I am a traditional person. When I mean traditional, I like to do things with my hands. When I do a lot of speaking engagements, and I like to develop my slide from scratch and put it in such a way that express what I want to say. But I begin to discover that sometimes I can't meet up with a lot of speaking engagements, and all I have to do is to decide on the kind of presentation I want to make, and just go to AI, get my context ready, decide on the theme, decide on the color combination, and start giving instruction. For instance, all these slides are AI generated based on my own content. Now, if I were going to sit, because these are some of the things you will do as a community pharmacist, if I'm going to sit to develop this from scratch, I would spend like maybe 3-4 hours. But with prompts, in 10-15 minutes, you are done. And that's one of the reasons why you need to also understand the aspect of prompts, which we are going to get into. Now, in academia, which is also an environment I function in very well, we have it in teaching, we have it in assessment, we have it in research. And that's why when I have the opportunity periodically to interact with pharmacy students in training, one of the things I always mention to them, especially in this age, is as you are going through your training, you need to adapt and adopt technology alongside with it. Either we like it or not, AI has come to stay. No matter the fear, no matter the concern, you can't take it away. All we need to do is to ask ourselves, how do we integrate it into practice? Now, for pharmacists in the industry, it could help you towards regulatory intelligence, then research and development support. Then for pharmacists in public health, it could help you in data analysis and also surveillance. Now, there are patterns in data that AI will discover faster than you just trying to look through the data yourself. Those are some of the aspects. Then for regulatory pharmacy, especially in policy reviews and document analysis, there are things in certain documents, especially you have some documents to go through over a very short period of time. There are some patterns, there are some frameworks, there are some data that you may not be able to see by reading. But once you put it in an AI and you put the right prompt, it's going to bring it up. I remember I was going through a particular document for an organization. They shared their concern with me that there is a particular pattern they notice in the policy and they are trying to make a correction. I was reading it, I was not picking it to the level that I would desire. I just decided that, okay, let me run this thing with AI. And AI picked like 5. I only picked 2. AI picked like 5. And I had to ask, please indicate the actual page. And because we human, we experience what is called fatigue sometimes. Cognitive fatigue, cognitive decline. But the machine will not experience a cognitive decline. So that's why it's important to use it as a working tool. Now, for you as a pharmacist, which of these applications would save you the most of time in your current role? Take a time, just think through your current role. Look at some activities that you carry out. Look at some activities that you are involved in that you feel that you are almost not having enough time. Then you begin to ask yourself, are there tools that can help to do a better work in this particular area? Now, it's important to establish this, that AI is powerful but not perfect. And I will repeat that again. It is important to accept this fact that AI is powerful but not perfect. I remember early in the year, one of the lecturers at the Faculty of Pharmacy just came to me. He knew that I'm so much involved with AI. It was like, for like almost a week, I need to see you. So by the time we were going to see, it was like, there is something I need to bring up to you. This AI thing, I need to pay attention. I said, what's the problem? Now, one of my projects, he was referring that one of my project students submitted some part of her work for me to read. And when I read through, it was so amazing. I was like, wow, this is good. So he now asked the student, please, can you throw more light to this? Then I said, please, man, let me confess, I use AI. He was so shocked because they were beautifully crafted, important information that you are going to look and say, wow. But take note, in the middle of this, sometimes there are errors. And that's one of the reasons I will go back to what I started with, that there is no way AI can function effectively without subject matter experts. And we're still going to get into such application. Now, like I mentioned earlier on, that there are opportunities in AI, faster research, faster turnover in research, improve productivity, better access to knowledge, and enhance communication. However, it also comes with risk, which we should be aware of, hallucinations. Now, one thing I've observed with trends with respect to development and progress in artificial intelligence is the rate of hallucination has decreased compared to what we used to have some few years ago. 2-3 years ago, there were lots. In fact, 2-3 years ago, you could use an AI machine and you are going to ask the AI machine who is the president of Nigeria, and it's going to be telling you the previous president, not the present president. But a lot of development has taken place. Technology keeps getting better. It keeps improving. And that's one of the reasons why today we have very serious aspect of the security of AI called deepfakes. That in such a way that all they need is your voice, your picture, and they turn it into a video to say what you never say. And to be in a place where you never were. Okay. So, we can have hallucination take place where the machine gives you an information that is not right, but it's going to be painted in such a way that is right. Now, especially for those who use artificial intelligence for research, and it comes up with a reference, and you discover that the reference was beautifully written, but when we go to check the reference, it's not existing. And that's one of the reasons why it's very important to take note of this, that AI can hallucinate. Because why? It must provide answer. And when the answer is not in his own database, it just cook up something and present it to you. Now, also we can have incorrect medical information. Now, we are going to get to the aspect of prompt engineering, how to prompt effectively. Now, if you don't understand that AI can provide incorrect medical information, you just take everything given to you by AI, like one of my prof will always say, hook, line, sinker, fisherman, and boat. We'll take it together. Okay. So it's very important to take note of that. Then AI can show bias. I remember overseeing a project, and they were developing a model for a particular AI project. And at the end of the day, the AI is supposed to carry out some activity. However, they used data of right-handed people to train the AI, forgetting that some persons would be left-handed that would use the solution. So at the end of the day, that particular model becomes biased against left-handed people. Then that's also the challenge we have. That's one of the reasons why Africa must start producing its own solution. Most AI solutions from the West is only paying attention to peculiar situations in the West, not in Africa. And that is why there are sometimes you write some things, I've experienced that you write some things and it is placed out to be reviewed, especially with all this plagiarism using this tool. And the same thing you sit down to write yourself is going to say it's AI written. Why? Because that machine was not trained in our own African way of expression. But like I said, a lot of development is taking place and this is being corrected. Then confidentiality breaches. This is very important to pay attention to, especially as we begin to look into AI. Now, it's very important to trust but verify. That's the golden rule. Trust but verify. I want you to repeat this at the count of 3 after me. Trust but verify. 1, 2, 3. Very important. Trust but verify. Because of time, there are some things I have to say, but let's just go ahead. Now, remember, every AI output must be reviewed, must be validated, and must be professionally interpreted before use in patient care, research, or education. Now, where are you on the AI adoption curve? Are you a skeptical observer? That is, I'm not convinced AI is relevant to my work. I was speaking with someone that, I'll be coming to Lagos to speak about AI. He said AI is not ready. People have their own, bias. Now, for some persons, they will tell you, I'm a curious beginner. I'm learning about AI and exploring possibilities. We have occasional users, which we have most persons. Occasional users are use AI tools occasionally for specific tasks. Then we have the regular users who use AI tools for almost everything. And I remembered watching a clip. The clip seems funny, but it comes with a lot of message. The clip put up something like in 2035. The man came into the room, knocked at the door, and the person said, you can come in. He went to his phone chat. The person said, I can come. What should be my response? The AI gave the response. He went to the person, tell the person what the AI said. Then the person asked the question again. What is the process of, he went to AI, type again, what's the process? What should be my response? Now, there is what we call cognitive atrophy. When you use AI too much and you are not exercising your own cognitive ability, you start losing it. And that's one of the reasons I always encourage people, no matter how much AI helps you, sometimes put it aside and think. As a matter of fact, I was speaking in an event and I proposed a particular model for AI use, which is a sandwich model. Don't start with AI. There are some persons, any little thing, think about the process yourself, go to AI, then come back to yourself to complete it. That's very important to take note of. Now, a real world scenario. Let's imagine you as a pharmacist, you have just been asked to conduct research, prepare a presentation, or educate patients and summarize new evidence. How can AI help you accomplish all these more efficiently without compromising personal judgment? Take note, without compromising personal judgment. Now, remember, you've been asked to conduct research, you've been asked to prepare a presentation, you've been asked to educate patients, and you've been asked to summarize new evidence. Now, AI can be your intelligent assistant. It should not take over your work. It should not take over your thinking. It should be your assistant so that it can help you to save time, improve quality, and also make better informed decisions. Now, from research questions to evidence in minutes. This is one aspect that I have used AI a lot. A pharmacist wants to investigate whether AI can improve medication adherence among hypertensive patients. Now, there are different AI tools to use, but Elicit plays a very great role because each of these tools are built according to different goals. Now, ChatGPT could work if you understand how to prompt, but not everybody understands how to prompt. And we are going to quickly look at that before we conclude this. Now, you would be asking the AI to refine a research topic. You are coming up with a topic, you are not sure what it look like. You can ask AI, what do you think about this topic? What are the things to consider? Now, the reason why when you ask AI is AI has more exposure to more database than you do. So you already understand what has been done around this in different parts of the world that you are not even aware of. So it's very important to take note. Because of time, we have to move fast. Now, turning information into professional outputs. You know, there's a research paper. You need the keywords. You need to summarize. And you are not having the time to read through the whole thing. Why? Because you need to synthesize like 5 or 6 research papers to be able to bring out some direction for yourself. That's one way AI can help. Then create key findings. You are looking at a research paper and you just need, what are the key findings in this paper? I mentioned it earlier. AI can help you to do that. Then generate a presentation outline. You could decide that, okay, probably you have a research and you are called upon, oh, come and give us a summary of this research in like 5 minutes. And you're like, oh, what's going to be the important thing? You can put it in AI, and AI can help you to bring out the key outputs of your work for you to discuss. In fact, you can mention, I only have 5 minutes to talk. It will give you the amount of time. Because initially, I prepared a 3 hours workshop. Then later, I got information that I'm going to be speaking for less than 40 minutes. I only have to ask AI, distill down to a 40-minute talk, then pick out the most important thing that would benefit this particular professional group. Now, better prompts, better results. This is about the prompt engineering aspect of it. And please, take note of this framework for prompt. A lot of people approach using AI prompts and just dump message in there. Dump queries, dump question. Number 1, you need to give a definition to AI. Now, AI has multiple forms. That machine has multiple forms. You will be the one to decide what form do you want this AI to take in responding to this answer or to this question or to this query. So you need to define the role, decide on the role, then now decide the task that you want carried out, then decide the context and also decide the output format, then probably quality requirements. For instance, there are sometimes when I put in anything to AI, there are some information I include, and I would say this, that any response you are providing must be verifiable. Yeah. So if he's providing information for me, he's now including real references that I can go to check. Because if you don't mention it to be verifiable, he can also still come up to cook up some things that you may not even pick it. Because remember, it's going to look so real and so amazing. Now, This is an example of prompts. See, look at the first line there. That's the role. You are a clinical pharmacist. Sometimes to improve quality of what I'm going to get, I could decide that act as a clinical pharmacist with over 15 years experience. Now, let me tell you what will happen. Immediately you put up this prompt, act as a clinical pharmacist. The only response the AI will give you is going to be response from clinical pharmacists around the world that has experience in this area. But if you don't put this, it's going to bring from tabloids, it's going to bring from magazines, it's going to bring from what one secondary school boy posted online that is on the online. It's just going to bring everything and mix it up together. And that's why you discover that we can ask the same questions in different ways when interacting with AI. Then you could also, for instance, the task could be to summarize latest evidence on GLP-1 receptor against type 2 diabetes. You are given specific tasks, which is very important to take note of. Now, before your 90-day plan, this is very important for us. Like I said, either I like it or not, AI is here with us. But as professional body, we need to begin to also ask ourselves, how prepared are we with respect to ethics that comes around using AI in pharmacy practice, both industry, community, and academia. It's very, very important that we realize that responsible AI starts with responsible pharmacists. And if there is nothing I would say, take note of this, that AI should enhance professional judgment, not replace it. If I'm not going to say anything else, it's important to take note that AI should enhance professional judgment and not replace it. And that's why anytime, make it as a rule of thumb. Anytime you decide to use AI, before you go to the world with your result, please sit back and read through the output all over again. Even the best of companies around the world, they are falling victim of this. I don't know if you follow information in this line. There was a time Deloitte had an issue in Canada. One of the province of Canada actually employed them, gave them a work to do, to come up with documentation. And the person that they gave the work to, Deloitte, you know Deloitte is a global company, actually used AI, but did not go back to read through. And gave it to his supervisor. Supervisor also did not go to read through. Why? Because there was no organizational framework for AI usage. And that's why PCN should have organizational framework for AI usage. That at the end of the day, if it misses this particular group of reviewer can pick it before it is shown to the world. So it's very, very important to take note. Now, I would propose a 90-day plan for you. Step 1, learn. Just choose one. Now, let me tell you this. It is almost impossible to catch up with AI tools that have been churned out periodically. So you just need to decide, pick one to learn and master the usage. Then number 2, apply. Use AI in one recurring professional workflow. Just look for the ones that pertains to you. Then step 3, share what you have learned with your colleagues. Share what you have learned with your department, and if you have students, with your students. It's very, very important. And I'm going to also ask, whichever part of the curve you are in AI adoption, move on to the next. I'm going to say this, that we are going to get to a time that it is those who use AI to do their work that will become more relevant than those who don't. You, as a pharmacist, there are lots of opportunities that will come your way. But you discover that sometimes what could help you is how much you're able to take advantage of this emerging technology to do your work. Thank you very much. I'm going to stop here.
Wow, thank you so much. Can we appreciate Mr. Matthew? That is lovely. We've all heard it all. So those of us that we've been nursing fear in using AI, we've heard it. Those of us that have been using it, not taking into consideration the ethical aspect of it, we've heard it all. Those of us that relies on it, we've heard about the cognitive decline. When he mentioned that cognitive decline, something struck my mind. I say, oh, no wonder that the students of nowadays find it difficult. Hello. So that means I'm not the only one witnessing it. The students of nowadays, there's something else. So because of AI, I can now see the reason. Because sometimes, of recent, I gave some exam. It's not to pharmacy students. This has nothing to do with pharmacy. Just what I mean is it's not professional, just communication skill that you can even give to English students. They can't answer it. I was wondering, what is the problem? I can now see it, cognitive decline. So we will now know how to tackle it. We should know that AI is an opportunity for us. Mr. Matthew, please sit down. It's an opportunity for us to integrate it into different areas of pharmacy profession. It's useful in clinical pharmacy, in a community, in academia, what have you, in research. But we should take ethical issue into consideration. And of course, we have to apply it responsibly, okay? We shouldn't be afraid. AI cannot replace us as a pharmacist. AI has its limitation. Remember, there must be a subject matter expert before you can use AI. So at least that has given us assurance. We've seen it also that AI is biased. So as such, whatever you put into AI, you should verify. So these are some of the things, among others, that we have learned today. So the floor is open now to questions. Please do ask your another expert, IT expert, has not even allowed me to finish. He has started raising. So please feel free, clarification. Even though, remember, he said he will have given us this capacity for 3 hours. So that means that this is just the tip of an iceberg. And Mr. Matthew, please, if you come to you, do open your door to us to ask questions. So Dr. Ike Bello, over to you. So please, times to ask questions.
Good afternoon, the chairman and our lecturer. A very good one. I have just 3 questions. Three questions, sir. Just 3. Okay, 1 question. 3. 3 more. Question number 1 is, I want you to about differentiate between hello. Okay, I want to write down. Yes. Once again, I want to thank you for your lecture. Very impactful and very educational. Number 1, I want you to differentiate between prompt engineer and context engineer. Context engineer. Engineer, yes. Then number 2, AI literacy and AI fluency. What are the 2 differences? AI fluency. Yeah. Then number 3, we are talking about AI and many AIs, many tools. But most of these are pro versions. And what you are available to us are free version. So when you want to buy this, they say 30,000 naira, 20,000 naira. I want to use it as many as possible. Be AI expert. How do you think we can go about getting at least an arsenal of AI with a lesser pay? Thank you.
Thank you very much. Okay, ma'am. Okay, that you have a training platform? Yeah. That is the question. Okay, thank you. The last question. Okay, Dr. Wafro, please. Oh, yeah, take.
Thank you so much, Mr. Matthew, for the presentation. It's wonderful. AI is very good. I know I delivered part of lecture on AI some years back, but I don't know why I have never used AI once to date. I don't like it. I never loved it. And I don't think I will ever like it because I always like my brain to work 24 hours. There was a day I was trying to conduct a research, molecularly in pharmacology, in what I know very well. I put it into AI. He fed it all of them. When he fed it, I say, as from today, I will not simulate with my natural knowledge with AI. I don't use it too, and I don't think I will ever use it. I know it's very efficient. Thank you so much.
Thank you very much. To conclude, no, just 3. We've taken 3. Please, one house. We've taken 3 questions, but this section will not be completed if I did not take questions from ISG as an academician, because this has to do with, this program has to do with West African Postgraduate College of Pharmacists. So ISG, over to you, sir. IPS.
IPSG. Yes, thank you very much. Our speaker has actually opened our eyes to AI. And the truth is that we cannot ignore AI. That is the truth about it. In fact, in my own presentation now, we realize that we will need AI to ensure that you battle antimicrobial resistance. If you want to carry out antimicrobial stewardship, you will need some form of AI just to assist you, not really for you to depend wholly on it. So there are many innovative things you can do with AI, and it's not as if you'll be relying fully on it. So I thank our speaker. Just wanted to ask, somebody asked a question. I'm not sure whether you answered that question. Oh, you have not answered the question. Okay. So mine, maybe let me just reiterate it. There are different AI tools, right? And for the profession of pharmacy, that is the practice of pharmacy, which of these tools would you recommend? That is, when I say practice of pharmacy, I'm talking about clinical pharmacy in the hospital and community pharmacy. That is where the pharmacy practice actually comes out. So we know that ChatGPT, if you use it very well, may help you. But specifically for pharmacy, do we have any particular tool you can recommend? Thank you.
Thank you very much. Over to you, Mr. Matthew. Okay. Answer it in under 5 minutes or less.
Thank you very much. Those are very intelligent questions. Number one,
please, we are making noise, please.
Someone asked to know the difference between prompt engineering and context engineering. Prompt engineering is, I will refer to it more as a skill that helps you interact with a large language model like ChatGPT to be able to get the best result out. And remember, I shared one of the models used in prompt engineering. But context is a smaller part. That is, what is the context will be what will guide the outputs at the end of the day. But prompt engineering is more of the larger house. You know, remember in prompt engineering, we look at roles, even in prompt engineering, we look at context. But context engineering only focus on the context itself, not role. Context engineering focus on the context, but not role. So that's why prompt engineering is more of a larger application, while context just focus on the context that you are imputing and you'll be expecting. Now, the question on AI literacy and AI fluency. This is something I would encourage everybody to pay attention to. In my own personal practice, interaction, and professional work, I discovered that a lot of people start using AI without AI literacy. And that's one of the reasons why when somebody asks about training, there was a time we had to run almost a 2-month training on AI literacy. AI literacy goes beyond I can prompts. AI literacy goes beyond I know the tool to use. There are lots of ethical issues that you need to learn. Even though you are not going to be an engineer, you need to be able to understand what the engineers they are going to do. For instance, there was a project that a particular research team, it actually has to do with pharmacy eventually. They want to digitize some traditional medical practice. And they were going to be interviewing traditional medical practitioners. And at the end of the day, they would be digitizing some of these things that these people are going to say without paying necessary attention to them. And, that's what leads to what we call biopiracy. That at the end of the day, you collect knowledge from me, no more reference to me, you go ahead and continue your work. So it's very important to realize that there's a big difference between AI literacy and AI fluency. You can be fluent in AI and not be AI literate. Very important. Okay. Then the cost for using AI, I always say that most of these tools, they actually have a free version. And personally, I always say this: don't pay for a tool if you have not explored the free version first. Explore the free version and get to a stage where you think you need to pay, then before you go ahead to pay. Definitely, we have many different training platforms. Probably I would reach out to the leadership of this association, professional body in that direction. Then, okay, concerning the person that talked about not using AI, I understand, but I know very soon it will change. But the only thing I would just say is, when you want to start using AI, you decide on use scenarios that you want to use it for. I'm going to give an example. I have some things to present, and we had a little bit of misunderstanding, and I wanted to make a presentation. But I was very concerned because I'm going to be speaking with a high-level delegate. I wanted to be sure if my words were the right words to use for a high-level delegate. Now, I just decided after I came up with my drafts, and now put it in AI, I felt I had the best drafts. And AI punctured a lot of that. When you are speaking to high-level delegates, take note of this. You don't say this. You don't use this expression. Those are places you can actually start from. Thank you very much.
Thank you so much. Oh, please, okay, 30 seconds. The tools, please. We're
the
going
tools.
to the seconds.
Now, let me tell you this. There may not be a specific tool at the moment. There are, but there may not be a specific tool available at the moment. And that's one of the reasons I started with subject matter experts. AI would not go ahead to, people with tech will go ahead to create any tool without having inputs. So the discussion can start with people that are familiar with this is what we want to do, what AI tool can be created. And don't be surprised, you don't need to go out of the country. There are people within this country that can create that tool.
Thank you so much. Please, can we appreciate Mr. Matthew? Can we appreciate him? Thank you so much. So, we'll be moving to the second segment of this, and that is closing the antimicrobial stewardship loop for optimized pharmacotherapy, specifically from the hospital. And who else can deliver this other than the experts? Experts in it, an academician, a public health, a clinical pharmacist, a public health pharmacist, somebody that has traversed all the aspects of our different specialization. No other person other than our prof, our immediate past Secretary General, Professor Oreagba. You are welcome, sir. Please, let's appreciate him. Let's appreciate him. He has done a lot for us and he's still doing it. So you're welcome, sir.
Thank you very much, my chairman. Colleagues, I'm happy to be here today to talk to you about antimicrobial stewardship. Well, I'm not acting in my own capacity. I was actually drafted by Dr. Usman to come and stand in for him to give this talk. He was supposed to represent us at UNILAG for a research grant. So we now split it into two. He will go for the research grant and defend it, and I will be here to stand in for him. So I'm actually standing in for Dr. Sekiru Usman. Now, I would like my presentation to be interactive. The slide is there, so they can share it. But let me ask one or two questions. As pharmacists, we are supposed to be involved in antimicrobial stewardship in our various hospitals. True or false? So for the hospital pharmacist, I just want to know, do we have an antimicrobial stewardship committee in place? That's one. And then are you a member, or do you have somebody who is a member of that committee in your hospital? So this is for hospital pharmacists. So I need answers. Yes, sir. Which hospital is that? UITH Learning. Thank you very much. And you have a pharmacist who is a member of that committee. Great. Yes. I sent you to Danraka. So that's good. Which other hospital? Any other person? UI or UCH? Massey Street in Lagos. Good.
Yes, they have antimicrobial stewardship in Metama stores now, but it's not
Good.
active.
It's not active. Okay. Those are the things I want to know. So for Luth, I know that Luth is active because I'm part of Luth and I work with them. Yes. UCH is very active. Excellent. Now, let me ask, what exactly do you do? Or the pharmacist who is a member of that committee, what does he do? What is his own contribution to the antimicrobial stewardship committee? Who can tell us? Let's just have one or 2 points. What do you do? Or what does the pharmacist do in the antimicrobial stewardship committee? Yes, you want to say something? Yes. Thank you.
Okay, Professor, I am not infectious disease expert. It's not my area. But I believe that what a pharmacist needs to do in antimicrobial stewardship should be very simple. One, what is stewardship? It is a performance. If stewardship is a performance, that is how antimicrobial does. As a pharmacist, what you need to do is try to know which bacteria, fungus, or thereabout are susceptible to some antimicrobials. Let me take, for instance, now. If there is the issue of Staphylococcus aureus, let me go for maybe Escherichia coli. And a physician now wrote amoxicillin to be used. Maybe 500 milligrams every 6 hours for 10 days. As a pharmacist, I'm supposed to know that amoxicillin will not be able to destroy Escherichia coli. There will be resistance. So it will not perform. I will be able to advise infectious disease expert, that is a physician, to look for a better antibacterial that will be able to destroy this. If it's Escherichia coli, I can tell him categorically, if that patient does not have any, because I'm a cardiovascular person, does not have issue, maybe like a QT interval, cardiovascular related problem, not to go to fluoroquinolones. You can tell the physician to go to cefixime or cefuroxime, which you know can cover both gram-negative and gram-positive, than going to amoxicillin, which is a penicillin that will lead to resistance. That should be the stewardship of the antibacterial. Thank you.
All right, thank you very much. So the pharmacist in the hospital, that is the infectious disease pharmacist, is to simply ensure that the antimicrobials are used rationally. That's basically what he or she will be doing, to ensure that you don't misuse, you don't overuse, you don't overprescribe, and you follow the guidelines. There's a guideline for antimicrobials in the hospital, specifically for antimicrobials. So the pharmacist will ensure that you follow those guidelines. Another thing it does is to calculate consumption of antibiotics. Okay? So I was eager to hear from you because you are the ones that are there practicing it. I'm just looking at theory. So I need to hear from you whether this is what happens. The other thing that the pharmacist should do will be what they call audits and feedback. Yes, prospective audit and feedback. You want to look at the case notes or the prescriptions and see whether they are okay. Where there are issues, you give a feedback to the team or to the clinician. These are things that the antimicrobial pharmacist should do to ensure that there is rational use of antimicrobials. That is your goal, to ensure that antimicrobials are used rationally. I remember about 20 to 30 years ago, 1996, 1997, we had this international network for rational use of drugs, INROD. I was the secretary of that group. And antibiotics, one of the indicators when you are measuring the performance of prescriptions is to find out what is the level of prescriptions containing antibiotics. That means that you want to reduce to the barest minimum the prescribing of antibiotics. So it has not changed 20 or 30 years ahead. As much as possible, we want to reduce the prescription of antibiotics. Then if you must prescribe it, you must prescribe it rationally. And then there are also some guidelines, like the AWARE guidelines, which will help you to now decide which of the antibiotics should I start with, which one should I reserve, and so on and so forth. So we shall be talking on some of these. Now, what is antimicrobial stewardship? So the title is Closing the Antimicrobial Stewardship Loop for Optimized Pharmacotherapy from hospital wards to community pharmacies. So you can see there are two things there. The first thing is that in the hospital setting, are we ensuring or are we implementing antimicrobial stewardship in the hospital setting? If we are, I say congratulations, but it has not ended there. The next question will now be, how do you maintain that stewardship from the hospital to the community pharmacy? How many of us are community pharmacists? Okay, good. So how do we ensure that that antimicrobial stewardship continues from the hospital wards to the community pharmacy? Because that is where majority of our people go to purchase their antibiotics. So the community pharmacist has a big role to play, and we shall also discuss it. So this is the outline. We'll give a brief introduction. We'll talk about AMS, antimicrobial stewardship, then the role of the community pharmacist. And then we'll look briefly at the AWARE classification of antimicrobials and how do we close the loop, that is the loop between the hospital ward and the community pharmacy. So that gap will be, cleared or closed. And then what are the challenges of implementing this? And then we recommend recommendations. Antimicrobial resistance is responsible for approximately 1.27 million deaths globally each year. Just because of antimicrobial resistance, people are dying. So people are dying every day, and that is one of the justifications for, in fact, the main justification for antimicrobial stewardship. Sub-Saharan Africa carries the highest mortality rates from bacterial antimicrobial resistance. And Nigeria, with a population exceeding over 220 million, is recognized globally as a high burden setting for antimicrobial resistance action. So we are a good place, a good setting to implement antimicrobial stewardship. So hence we are looking at this very critically. So I thank the organizers for bringing up this topic. So what is antimicrobial stewardship? You can see those 4 points. I've summarized it. You want to improve patients' outcome. You want to prevent antimicrobial resistance or minimize it. You also want to minimize adverse effects. In Luth, we have a very strong and dynamic antimicrobial stewardship committee. They had to draft me to come and be the pharmacovigilance person in that committee, because they realized that antibiotics, antimicrobials do have adverse effects. And there's a link between pharmacovigilance and antimicrobial stewardship. And then you want to decrease healthcare costs. So, what are the components of antimicrobial stewardship? Diagnosis, very important that you make the right diagnosis. You look at a non-antibiotic alternative for prevention or for control or for treating. Is there an option first before you jump into the antibiotic wagon? If you eventually agree that yes, this patient needs antibiotic, then how do you use it judiciously? How do you use it rationally? Okay, and then you keep on reevaluating. Okay, do you really need antibiotic for this patient? So you monitor your patient and be able to evaluate the outcome. So the goals, as we mentioned, we will continue to repeat it. You want to optimize clinical outcomes. You want to minimize toxicity. You want to reduce antimicrobial resistance, and that will translate into lower healthcare costs. So this requires multidisciplinary collaboration. So in any AMS committee, you find various professionals from different disciplines. This is something that you will find, something like this, in a very standard functional antimicrobial committee. They are working together for the right drug, the right dose, the right duration, and for the right patient. And each of them have their roles, okay, clearly specified. Let's look at the role of the pharmacist. It's to ensure that optimized antimicrobial therapy, review interactions and allergies, then look at the formulary and ensure that the formulary is being adhered to, and then educating the patients and the healthcare providers. These are the roles of the pharmacist in the Antimicrobial Stewardship Committee. In addition to others, I mentioned calculating the consumption. You have to calculate regularly to see whether are we really doing well or not. Then the review, that is a prospective audit and feedback. These are very technical roles that the pharmacists in the hospital setting should, be involved in. So, from the hospital ward to the community pharmacy, all right? What are the roles of the community pharmacists with regards to antimicrobial stewardship? He received the prescription. One of the very important things is that you must ensure as a community pharmacist that you want to reduce prescriptions, that you want to reduce the number of antibiotics without prescriptions. That should be one of the targets for a community pharmacy. As much as possible, you want to ensure that the antibiotics are prescribed by the clinician. And in our environment, it's not that easy. But it is doable, it is possible. So by the time you talk to your patient, you discuss it with him or her, educate him or her, they will realize that it's important that they see a doctor before using antimicrobials. So ensure that if you now receive a prescription, you validate the prescription as usual. If you look at these two prescriptions, you can tell what is wrong with the prescription, the second one. One of them is signed, one of them is not signed. So a patient can just come up with a prescription that is not signed. Check for inappropriate doses. These are looking at the drug therapy problems. I won't take much time on this. We are all used to this. Check for drug interactions. A lot of interactions or potential interactions take place between antimicrobials and other drugs. And we shall see some examples here. Usman et al., they did a study looking at antimalarials and antiretroviral drugs. And when they did the general prescription pattern outlook, they found out that there were interactions between antiretrovirals and antimalarials. But it now went further to do a clinical study to find out, is there really a big difference? Is there really a clinically significant interaction between antiretrovirals, that is efavirenz, and the lumefantrine in that combination of antimalaria? And he actually found out there was indeed a significant difference. That is, efavirenz significantly reduces plasma concentration of lumefantrine. This is a very key finding that should change or influence policy in the ARV clinic. So that is why drug-drug interaction is very key. And that is why we need to do all of those drug therapy problem assessments for each prescription that we look at. Ask questions about allergy and pregnancy status. Dispense complete doses of antibiotics. Thank you. And you can see what will make adherence easier. Rather than having different sachets, you can pick the one that has a combined one before giving to your patients. Counsel your patients. Documentation is very important, both for the hospital and the community pharmacist. For the community pharmacist, you must have your own file for your patients. Each patient must have his own file. Better still, electronic documentation is very key, especially in this age of AI, in the age of advanced IT. So if you have a system or an app that will capture the details of your patients, so you can always refer to that app, and it will be easier for you each time you see your patient. So these are the details of the patient that you should capture: name, gender, dose, concomitant drugs, and so on and so forth. You are all very familiar with this. Laboratory test results, very important. And then, is the use of antimicrobial justified? And then, any adverse events. These are very important for your patients. And of course, you follow up. Then again, you must be aware of the antimicrobial prescription guidelines and use your pharmacy labels very well. rapport with the clinicians, he would know based on their rapport. Incomplete discharge summaries. When a patient is discharged, the next thing is that it must go with a discharge summary so that the patient can continue from home and, of course, from the nearby community pharmacy. Lack of follow-up on cultures and sensitivity tests. So what we are now saying is that that network between the community pharmacy and the hospital wards must be strong. It's lacking currently. And that is one way we can close the antimicrobial loop. Otherwise, our patients will be confused about duration and adherence. So what are the core concepts? It has to be bi-directional, not just unidirectional. So you have the hospital, you have the community pharmacy, and then you have the clinicians again. So ensure therapy remains appropriate, and it ensures real-time interventions. If you want to intervene, immediately you have a link with the clinicians. So the responsibilities of the AMS pharmacists in the hospital is to ensure that the discharge summaries are properly articulated for that patient. So when he's going out, that is attached to whatever prescriptions are taken up. Indication must be properly stated.
Recording in
dosing
progress.
Frequency, duration, culture results, all of this. So you might want to wonder that how can all of this be given to the patient? All right? But if there is a network between the community pharmacy and the clinicians, they can actually direct it straight to the community pharmacist, and it makes everything so easy. For the community pharmacist, he will verify antimicrobial appropriateness, check renal and hepatic dosing, identify interactions, counsel the patients on adherence, and then report concerns back to the prescription, to the prescribers. So you can see that technology is very key here. Integrated electronic health record systems, meaning that at your pharmacy, you have an application that captures or that can be linked to the electronic health records in the hospitals around you. We've not gotten there. We have to get there. Shared antimicrobial stewardship dashboards, when you have a similar AHR, that will happen seamlessly. Secure pharmacist clinician messaging, so you can reach out to your clinician very easily. Standardized discharge templates and mobile apps for patient follow-up. So all of these communication tools are very key. This is just an example. A 65-year-old with pneumonia being switched from IV ceftriaxone to oral amoxicillin clavulanate. What is the role of the community pharmacy? Confirms correct dose for renal function, educates on 5-day duration, flags potential interactions with warfarin, because there's that interaction between co-amoxiclav and warfarin. Then contact the prescriber for those adjustments if needed. So all of this will bring a very good outcome. And the benefits, when you close that loop, you have reduced antimicrobial resistance, fewer medication errors, improved patient outcomes, lower readmission rates, enhanced collaboration across care settings, and that will translate into cost savings for the health systems. However, these are the challenges that we may face when you try to implement closing that loop. Fragmented health records. First of all, we've not really gone digital, so that is a problem. Limited pharmacist access to clinical data, like I mentioned. The community pharmacists may not have access to the clinical data of the patient. Time constraints and inadequate manpower. In the era of JAPA, even the pharmacists that are supposed to carry out this function, they are not even there, or they are very few, and they are so overworked. Lack of standardized communication pathways, and then variable training in AMS principles. What are the recommendations? There should be a national antimicrobial stewardship policy, including for community pharmacists. We don't have one currently. We need to have that in place for community pharmacists to close that loop. Training programs for pharmacists, incentives for collaborative practice, digital tools for seamless communication, and public awareness campaigns on antibiotic misuse. What is the future of closing the loop You can see AI-driven decision support, real-time antimicrobial dashboards, predictive analytics for resistant patterns. AI will do that for you easily. Expanded pharmacist prescribing authority and community-based AMS clinics. In conclusion, antimicrobial stewardship is everybody's business. And the community pharmacist plays a significant role in this. So if you close the loop, then you're optimizing therapy. Collaboration plus communication will give better outcomes. And the ultimate beneficiaries are our patients. Thank you very much.
Wow, let's appreciate Prof. Let's appreciate Prof.
These are a few antimicrobial stewardship campaigns that we can actually put in our hospital settings that will really educate the patient within just a very short time. Thank you very much.
Thank you so much, dear Prof. Please, at least they've given us lunch now. Let's appreciate Prof. Let's clap now. Hava. Thank you very much. I want to ask us one question. Something is speaking to us here since morning. Who can tell me that? Something is speaking to us from AI. Antimicrobial. Antimicrobial is speaking to us through awareness. And that translates into antimicrobial stewardship. That is the framework. Today alone, first of all, let me appreciate the organizer of this. Those that sat down and thought that we should have this presentation. If you look at it, if you actually follow sequentially, the oral we had 8, though it was 6, that were finally presented. 2 out of it spoke to us on antimicrobial. Prof is speaking. In case if you have forgotten, the first oral presentation has to do with antimicrobial prescription pattern using World Health Organization aware list. And we had all this: misuse, no guideline, no following. Then the other lady also mentioned, the one I was asking about meropenem and puree authorization. Are you following it? Now, with what Prof have just finished, and you can see in his conclusion, there is AI-driven there, AI-driven support. So something is, we should not leave this place today without you maybe identify 2 or 3 persons from your zone or from your area that you're going to sit down and think about a project topic, a research topic that you will carry out. Antibiotic, antimicrobial, new ones are not coming up. So therefore, let us preserve the old ones. So thank you so much, Prof. We really appreciate it. Please, those online, they were protesting that they had questions in the chat box. We did not carry them along. Hello, do we have online participants? We appreciate you. Any question for us? For the presenter? Are we still there? Before we take physical, we're giving you the opportunity. Okay, while we await them, questions for Prof. Okay, 1, we're taking 1, 2. This side. 1, 2. So no one from here. That is 3. Okay, so thank you very much. So number 1, number 2, number 3. So over to you, sir. So we're going to take please let's check the WhatsApp platform. Maybe online they've dropped question there.
Thank you, Prof, once again for this highly speculative presentation. My own, will I even say question or worries and then suggestion? The number 1 worries is I remember when I was a superintendent pharmacist in one of the pharmacy, I won't mention, several years ago. Of course, whenever I'm on duty, the patients are happy to come Why? Because I always do the best for them at the lowest possible. But the employer called me that this will not generate your salary. That is the truth. And I believe it's still happening like that. That's number one. Now, talking about the collaborative relationship between the hospitals and the community, I'm looking for a day when the community pharmacies will have a focal person, pharmacist in each of the hospitals. Prescription come from so many physicians, so many clinicians, but when you have a colleague, let's say General Hospital, Yaba, and all the pharmacists around know that, okay, pharmacist Tijani is there, make him focal person. Let that relationship be between AHAP and ACPN, and then the loop will be closed. Thank you very much.
Thank you very much. Please, I have one online chat here, question here. The first one, Mr. Matthew will give you that opportunity, AI session. We are reading about the founders of AI sending alarm messages that AI can become uncontrollable and do its own thing, especially the agentic ones. So how do developing countries like us mitigate against this, especially as we are now using it in healthcare settings? That is a question to you. To you, Prof. Sir. She has a question here. Some of the presenters mentioned one of the reasons for no adherence to the AWARE principle is because physicians panic during emergencies and use reserve antimicrobials as first resort, even without sensitivity tests. The question, how can pharmacists champion collaboration between all healthcare participants and relevant stakeholders, e.g. the lab technician, physician, and even AI engineers in developing validated and verifiable quick test kits for their antimicrobial agents in hospital setting before use? That is a question for you, sir.
Thank you very much, Prof. I want to ask my first question. Is this AMS integrated to the school curriculum? Because that's the beginning. If it's not in all the NUC, we need to ensure that is actually there. Number two, the gap is so wide, and it's not something community can say, oh, we want to do, or pharmacists. It's got to be interdisciplinary network that we have to do it. I mean, it has to be a national thing. That, the time we went for Zinetrum or Inroad in India, I had whether it was Inroad or for Wapcp, I had a test in India. That was Hyderabad, we had the test. If I go to any other place, they will just go into the system. I can get all my load down. I can go to New Delhi. They will check there. We need to have that in place. So that, because we don't have that, where prescriptions are dumped there and we can know what goes on. It's not something I like these things, but there must be platform to operate this.
Okay. Thank you very much. Dr. Funshaw, you are the last, please. Our time is up before they kick us out.
Thank you, Prof. We are still seeking our place in the clinical setting. So, and I believe that Prof, using the word clinicians, was referring to physicians and prescribers. Okay, sir, I want to be sure. Thank you. My message is clear.
Okay, thank you very much. Okay, Prof, sir.
Yeah, thank you very much for the very wonderful questions. The first one is about collaboration. Is it easy that we need to have a national antimicrobial policy? Yes, we should have a national policy. But let me tell you, if you go to General Hospital, any General Hospital, you will see community pharmacists well positioned strategically by that General Hospital. And you will even find out that the pharmacist or whoever is in charge will go there and start talking to the pharmacist. Look, prescribe our drug. Make sure you prescribe our drug. So they're already marketing their pharmacy without national interference. So what are we asking us to do? you follow the same model, but now doing it in a more professional manner, meeting the MD, the CMD, or the CMAC of that hospital, and marketing yourself, and then enlightening him or her on antimicrobial stewardship. By the time you book an appointment and download some of these facts, you will have an ally that you can rely on, and he will rely on you. So people are already doing it already, but for business gain. So we want to do it to benefit our patient. Secondly, on the problem of prescribing watch group of antibiotics or even the reserve group of antibiotics in case of emergency. Yes, that is understandable, but it can also be dangerous. So what you will do as the pharmacist in the antimicrobial stewardship committee is that you carry them along, educate the prescribers on antimicrobial stewardship, the problems of antimicrobial stewardship, the AWARE guideline. I remember when we were implementing the AMS guideline in Luth, there were sessions to train consultants, there were sessions to train medical officers and the other healthcare providers. So when they go through these sessions, you now you develop the guideline together. So that when you now say, this one we cannot prescribe this, so you are together, they will agree with you. So it is doable once they are all carried along. Lastly, the curriculum. Currently, in implementing the AMS guideline in Luth, we use medical students to assist in the audit feedback. So in the curriculum, there is no strong AMS curriculum or module. We are just giving them the principles of antimicrobial resistance, but antimicrobial stewardship is yet to be fully ingrained in our curriculum. So it's a good recommendation that all pharmacy schools put it in their curriculum. Thank you very much.
Thank you very much, Prof. I just want to share a practical aspect of the way we can contribute. Like my presentation I made in the morning, the facility that I conducted the research, after presenting the prescription pattern, the next question they asked me, I spoke with the MD. The MD said, pharmacists, how can we help us to establish the antimicrobial stewardship committee? That was the question. And I now told them how that we're going to meet and then join them because they were not having guideline as well. It's more to it. So we can also establish this by evidence-based. Even if it's small, it might not be a sample size for research. You can just take about 100 prescription or look at 100 antibiotics prescription and look at AWARE classification and present it to the facility. That is one of the reasons. Because they too, in fairness, they are battling with antimicrobial resistance. So that is what it is. Sorry, please. This book, Pharmacy Jurisprudence, is on sale, 20,000. Mr. Matthew, answer your question so that we can close the section. You're supposed to have. We have 2 minutes. Okay. 1 minute for you, then 1 minute for picture with the team.
Yeah, the concern the person actually raised is real. And that's one of the reasons why in AI literacy, we encourage avoid black box. Black box is an AI pattern and process that cannot be explained. So that's one of the reasons why it's very important when you are using any particular AI, especially agentic AI, should be explainable. That's why we also talk about the explainable AI. It should not be something in a black box that they will tell you, this thing can't be explained. It should be explainable. Once it's not explainable, that's when you're going to start having issue of the AI misbehaving, like the person expressed fear and concern.
Thank you very much. On behalf of the School of the West African Postgraduate College of Pharmacists, I want to express a sincere appreciation to Mr. Matthew and to Professor Oreagba for this educative session. Thank you very much. Okay, to them. Okay. See him. So, as a sign, I want to start with the first presenter. As a sign of our sincere appreciation, this will be presented to you from the West African College of Pharmacists, Nigerian chapter. Okay, we should come. Okay. Thank you. Are you okay? So, Mr. Matthew, on behalf of the ESCO and members of West African Postgraduate College of Pharmacists, Nigerian chapter, I'm presenting this to you as a sign of our appreciation to you for that impactful lecture. Thank you very much. I now call on our dear Professor Oreagba, our immediate past Secretary General. Professor Oreagba, you are always there for us anytime we call on you. So we want to appreciate and thank you and your team for this research and for the impactful presentation. So in our appreciation, we are giving this to you as a token of thank you. Okay, Mr. Matthew, group photo. Chairman, come this way, away from the lights. Chairman. How are you, man? Are you ready? Thank you so much. Okay, please, you can stand just to stretch your leg for the next 1 or 2 minutes before we start our next session. The next session is actually an interactive session with fellows, the people that will steer it. I will call on Chairman of the Consultant Pharmacists Association of Nigeria, Association of Consultant Pharmacists of Nigeria. Dr. Onedu, please come to the high table. IPC man, Dr. Obono, please come on board. It's like a town hall. Please come on. It's going to be very brief. I know the day is fast spent. Me and her. Yes. Thank you. That we're having a program. That program was yesterday, and I needed to give her support. So Dr. Obono is a panelist in this session. Oh. Huh? Okay.
Then I will join her to support. Okay, please, we want to start. It promises to be very brief. The day is fast spent. I will hand over the mic to our own chairman of the ASCOP, in person of Dr. Titilayo Onedo. Ma, you have the floor.
Thank you very much. Thank you very much, Dr. Thank you very much, Dr. Danraka. And I also want to thank the leadership of the college Nigerian chapter for giving us this platform to be able to address the fellows and the appointed consultants here present this afternoon. As I've been introduced, my name is Titilayo Onedo, and December 2025, the PSN, the president of the PSN set up this interim committee of the Association of Consultant Pharmacists of Nigeria. Dan Raka here, seated here beside me, is an unofficial member of the committee. I've seen Timmy, Dr. Timmy Pre, Okero Gene is also a member. Solomon Nwafuru, Dr. Solomon Nwafuru is also a member, publicity secretary, and I've seen pharmacist Christopher Ugu this morning. I don't know if she's still here. And yes, Assistant Secretary Pharmacy Zuera, she's also here. Can you please stand up for recognition? All those that I have mentioned, can you please stand up for recognition? Thank you. So, as I have said earlier, it's an interim committee set up by the PSN, and let me just inform you that this Association of Consultant Pharmacists was actually registered in 2004, but it has actually not been fully operational. And when the committee was inaugurated, we were given the mandate to reposition the association. And as we are all aware, a lot of water would have passed under the bridge from 2004, even up until this moment. So there's going to be a lot that is expected of us as a committee and as fellows and consultants. So the association really is actually going to operate like, MDCAN. MDCAN is institutional based. We don't have MDCAN as a state structures. We have them based on the institution, and that's what we want to be doing. And I would also want to tell us the terms of reference as stipulated by the PSN. The PSN actually wants us to get the database of the consultants, both the appointed ones and the fellows that are yet to be appointed. I think we have already set up a platform, though not yet very active, but we have a platform in place already. So I want to use this opportunity to appeal to our members to please come on board. And like I said, we are aware that not all institutions have actually implemented this consultancy cadre. So for those who have been appointed, they are our full members. For those who are fellows of the college and yet to be appointed. We have decided that they are also our members, but they would come as associate members. So the platform too is for you. Don't let us think that it's only for the appointed consultants. And the second mandate is for us to create awareness at the MDA's level, at the Ministry of Health level, and that we have done. We have started that. When we were appointed, we wrote letters to the minister, the senior minister and the minister of states, and they actually acknowledged. And after we wrote the letter introducing ASCOP, we have also written to the ministry for the implementation of this consultancy across, all the federal health institutions and the other health institutions that are not hospital-based. Then for the states, we are aware that some states are fully compliant and some are yet to implement. For those who are yet to implement, we also wrote the executive governors of those states. And out of all the states that we wrote, only one state responded. That's Plateau State. And we have had series of meetings with the Commissioner of Establishment of Plateau State and Head of Service of Plateau State. And we are hoping, because we had meetings, and I think we have got to the final stage of them implementing the consultancy cadre. We were told that the governor is actually interested in implementing it, but they really didn't have full understanding, and that was what brought about the meetings, the series of meetings that we had. And we are praying that the letters will come out very soon, because about 2 weeks ago, I was still in communication with them, and I've been given the assurance. So that's that on the creation of awareness as to what we represent. We have been creating that awareness. And also, I would want to mention that because we wrote to Lagos State also, because, in fact, I don't know how to put it, but we are not so pleased that Lagos State, out of all the states, they are yet to implement this cadre. And we wrote to Lagos State, and we were invited to the House of Assembly to meet with the House of Assembly members, even though I wouldn't say the meeting was, successful, so to speak, but I wouldn't say it was a total failure, because they told us that when they want to come about with their own structure, that they will come, not calling it consultancy. They may call it something else, because Lagos has this special salary scale that they may not even want to use. But the thing is, they agreed that there is need for the implementation, and we are following up with Lagos State. Then another terms of reference is that we should actually make ourselves visible in the hospitals and wherever we find ourselves, and also to ensure that this cadre is implemented across board. And I think at this meeting, we are going to, be, brainstorming on the strategy methods. And the strategy method, for me, I don't think it should be like a size fit all, because it depends on who we are dealing with. You should know your institution. Given all you know about the headship of your institution, you should be able to say, okay, these and these are the best strategies to go about implementation of this cadre. So at this point in time, I would... Okay. Yes. So at this point in time, I would want to hand over to the immediate past chairman of the college, the Nigerian chapter, under whose tenure the consultancy cadre came into being. So over to you, Dr. Margaret Obono. Thank you, ma. My Oga.
Good afternoon, distinguished fellows and consultants. Yes, we are here to talk about, we've listened to the introduction by the chairman of the interim committee. We have been in this for quite some time, but by the grace of God, I think we can say we have made progress. Along the line, all the meetings and all the talkings and all that, we had people who swore they would never see it come to pass. But Comfy Chairman is here. I'm sure we have over 20 federal health institutions that have come on board, apart from state health institutions. And I know we are moving forward. Recently, one of the last I heard about was Adamawa. Adamawa State has also come on board. So they will come whether they like it or not. It's just a matter of time. Now, but while we interact on this, one major concern I always want to voice out is fellows, consultants, let's not just be after the title, but what is the value we are bringing to the table. If we do have value, bring value to anywhere we are practicing, so we leave no one in doubt as to what our potential is, why we should earn these positions that we are asking for. We also want the populace to be able to experience us, feel our benefits, so that when any other health professional is arguing about us being appointed consultants, the populace, the common man, the patient, the client will be able to say, I am a beneficiary and I think it should be this way. So that's one major thing I want everyone's focus to be. We have examples of fellows that have distinguished themselves, but some of us don't just bother. Some have silently, which we have not heard. Others are visible. But I think the goal generally is let somebody not even know your title, but see the value in you first of all. By the time he or she will ask, not say you don't know he is a consultant pharmacist or she is a consultant pharmacist. So I think I will stop at this and ask for feedback, right? So fellows, right?
Thank you very much, ma. Before the feedback, can we hear from Dr. Dan Raka, the CPC chairman, and also a member of ASCOP? Thank you.
Thank you very much, Chairman. I think I want to write on what the IPC has said, that essentially the focus of advocacy that we have been leading is to say that it's not only to put across that we are eligible to be consultant pharmacists, but rather to actually have tangible value addition in terms of how we improve the service delivery in our different facilities. Two important things I noted is members that are here are supposed to step down what we will agree here, that the structure of the ASCOP will be institutional based. It will not be that there will be ASCOP Lagos, ASCOP Kaduna, FCT or ASCOP, Sokoto, Bauchi or Rivers. No. There is going to be ASCOP in Federal Medical Center, Yenegua. ASCOP in Federal Medical Center, Abuja. ASCOP in Lut. ASCOP in National Hospital is going to be institutional based. Why we are following that structure is that is how you can improve capacity, put resources together, and address issues holistically. In the sense that we are stepping up our conferences and our engagement to be scientific based. So every fellow is already empowered to undertake average research. But all this capacity building we are doing and exposition we are doing is to now improve our skill to conduct operational researches on what we are doing. So that when you are talking, you are not talking from what you experience, rather you are documenting in a scientific way and churning out publications that the management will be the one to be looking out for what we are doing. So it's actually a paradigm shift that we are advocating for. It's not going to be easy because anyone involved in research, you know that in the beginning, you have to be investing in paying for publications and paying data analysts to properly, statistically put what you want to say in a scientific form. Definitely, as we improve our skill in conducting the researches and publishing, then we will have the capacity to apply for grants. There is an important partnership we are working with NAPA and others in academia so that our members are strengthened in scientific writing and publication processes so that it won't be business as usual. There is not going to be any excuse that a fellow will not in a year be able to publish at least once. Trends he has documented or interventions he has done. I think that is the paradigm shift that we want consultant pharmacists and fellows to take home and deliver at the institutions. I will stop here, then based on the feedback, we'll interact more. Thank you.
Thank you very much, Dr. Danraka, for the comments. So at this point in time, we want to ask for feedbacks from the fellows.
Okay, one. Let's take numbers.
Okay.
That's number one.
Number one.
Let's from this side, any other person?
Okay. Number two.
Please take your number 1, 2. Okay, 3.
Okay.
This side. First round. 3. This side, please.
Okay, 4.
4. Okay, first round.
I think it's okay.
4.
Okay. So
Number one.
can we have
Number 1, please.
Good afternoon. Hello?
That thing is not working.
Okay. Good afternoon. Good afternoon. The chairman, CPC, the members of the high table, and fellow members of the pharmacy of postgraduate West Africa College of Postgraduate Pharmacists. I am pharmacist Mrs. Arawa from University of Benin. My question and pain is that as at the time I was in the health center, Uniben, I actually rose to the position of a deputy director, and I benefited from the specialist allowance. But in 2000, I moved my services to the Faculty of Pharmacy, Clinical Pharmacy. And eventually, I lost the consultancy allowance, especially allowance. My question is, what's the chance, what's the benefit of the consultant pharmacists in academia? I'm sure even my lecturers, Professor Okpara, Professor Odile and all, they are not earning it. So when I raised my voice, by the time I got there, they said, chill, we are not getting it. I mean, what's the way forward?
Yeah, good afternoon. all the protocol duly observed. I'm pharmacist Ibrahim Yahaya from Abubakar Tafawa Balewa University Teaching Hospital, Bauchi. One of the few appointed consultants in the institution. We are lucky. The 5 of us were appointed in February 2026. As a way of feedback, in fact, I was thinking of writing maybe a book, The Consultancy Journey, from query to a consultant, because the major bottleneck, I look at them, one of the major bottleneck is within us. And we need to start breaking those bottleneck within us from the profession. A lot of bottleneck, because in my center is divided into two. Those that are for the program and those that are not against the program. In fact, the last person that graduated in my center was in 2018. And since then, there has not been any person that was even enrolled in the program until this year, when the letters of appointment came in. Single-handedly, the department sidelined us. The correspondence from the department with the management, whenever the management sent correspondence to the department, they kept it away. They kept it away from us. But we thank God, we follow the other route of unionism. I had to enter unionism and became a chairman of Nigerian Union of Allied Health Professionals. So I wrote directly with the management, and even though when the appointment came, it came with a lot of issues because there was no support from the department. Those that were supposed to get advancement couldn't get advancement. Those that were supposed to, for instance, even the nomenclature for the consultancy cadre was not properly put in place. So, but we thank God we are trying to correct it gradually because of nomenclature. When we first got the allowances, when some people got promotion, they changed the nomenclature from the consultancy cadre to the directorate cadre, and the allowances dropped. So we are trying to correct it because that happened last month. So we are trying to correct it this month. So how do we break some of this bottleneck within the profession? That's a question that I want us to brainstorm and ensure uniformity of this implementation. Thank you.
Thank you very much, the chairman and the house. I remain Dr. Tijani Muftau. Most of what I wanted to say is what he has said. So therefore, what I'm going to say will be a kind of a suggested way forward, which I know our elders will work upon. The challenges mainly are usually encountered when maybe the head of department or somebody that's supposed to speak for you is not a fellow or is not a consultant. So I want situations where whether we forcefully carry them along, because they have the knife in some cases and you cannot bypass them. So we have to just find a way around it politically, to see how we can bring them on board. Equally, if they want to frustrate you, they will give you schedule that will not make you to be able to practice as a specialist. Because we have clinics, and if I'm cardio endo, it is expected that I should be in the clinic where I'll be able to function. But you post me to where I will not be able to do well. So to store and say I should be doing it. So this is the area where we have to sit down and look at it. Today, most of these other professionals that are not even specialists, you will see a nurse who has been working in ophthalmic or high clinic for years. She will become uncertified specialist. You see a doctor who has been, in fact, there are some doctors that when I joined the service, I thought they were consultants. And they were not, because they were so knowledgeable in that aspect where they have been practicing for years without being posted out. So how much more we? So let's try and see whatever we can do. If Tijani is a critical care pharmacist, let him be posted to, even if it's A and E, if you don't have a critical, clinical said. If it's O and G, let that person be in O and G. And that will really help us. It will showcase our practice and we'll be able to move forward. Thank you very much.
Number 4.
Thank you, the chairman and the house. Mine is on, I agree totally with what Dr. Danraka said, suggesting that it should be institutionally based. But I want us to understand that we have both the state and the federal. Then we have some consultants that are working in the ministry, like the admin. Which group will those ones belong to? Indirectly, we are removing all those who are in the community. Is there a place for them? Or are we going to have another association for that group of people that are in the community, that are community pharmacists, or that are in the industry? Or because they are still consultants too. So even if we don't recognize them in this, are we thinking of having another group for that group of people? Thank you.
Thank you, Chairman.
Thank you very much for all these questions. I'll start with the last one by Oluwatimileyin. Yeah. So, Dr. Oluwatimileyin. In fact, like this, your question, I have never thought of it like this before. I know what we were told is to fashion out something in line with the MDCAN structure, and we know that MDCAN, they operate on, at the institutions. So even for the ones that are in the ministry or places like PCN, I know those ones can still have their own institutions. They can still have their own ASCOP. But now, you are now talking about the pharmacist in the community. We would want to ask because I know that there are consultants working in the community too. I don't know how. Yes, they are autonomous. So I don't know how they do that. Like most, the challenges with us is quite different from what we have with the community pharmacies, what they have. We in the hospital, or maybe the regulatory arm of the profession, the kind of problem, the kind of challenges, they are quite different, because we have to interface with the government from time to time, and I don't think the community people, I don't think they have such problem. So I don't think, at least for now, we are not looking at extending it beyond the federal institution, the health institutions, whether federal, state, or even the ones that are in the government, basically. Look, they are part of us. Anyone that is appointed or that is a fellow of the college, even if not yet appointed, they are part of us. But you must still be in active service. Even once you are retired, you cease to be a member of the ASCOP. If tomorrow, if I retire, I cease to be a member. So that's how it works. So because like I said, our challenges are really not the same. Thank you. I hope that answers your concern. Okay, thank you. Then for the question on the bottleneck, the challenges that our members are facing, especially when you have the head of department that are not fellows. And what's his name? Dr. Tijani actually also elaborated on that. I would want to let us know that ever since I took over as the chairman, ASCOP, have received so many complaints in this direction. Somebody who is a critical care pharmacist who is working in the store. Yes, so many. I don't know. And and I don't want to say that it's only the heads of department that are non-consultants that are guilty of this. I've heard of instances when the head of department is even appointed consultants, but still not recognizing sub-specialization. Honestly speaking, I don't know why that should even be happening. If really we all believe in this program ourselves, because if it is even like an outsider now, if it's maybe the medics doing this to us, we say, we are always very fast at pointing, accusing fingers. But when we ourselves, we are the one, even now, like undermining ourselves. I don't know what name to call it. And it is really happening because, like I said, I have received complaints. I have names of institutions. And now that is now coming to the fore, I think we have to do something about it. And I would want to say that we have reports already. I know some institutions that are guilty. So we at the level of ASCOP would want to engage those people. Let us see if after engaging and nothing is happening, then we now have to escalate. Because the truth of the matter is that some of us, like I've received complaints of when the medics are saying, oh, now we have appointed you people and you are doing nothing. And the HOD will now allude to the fact that, yes, they are not doing anything. I don't know why that should be. Even really if we are not doing anything, in quotes, because I don't want to even believe that consultants are not doing anything. And like I would always want to tell some people, is because even ever before we were appointed, some of us were already carrying out the roles and responsibilities of consultants. So now that we are appointed, some people now don't even know the difference because they are used to, having those roles and responsibilities carried out without being paid for. So I don't even think anybody should agree to the fact that we are not doing anything. We are actually doing a lot. But just that, like I said, some of the things that we are doing is the things that some of them we have been doing before without them being paid for. So that is what I will say on that. And like I said, we'll engage the HODs, the guilty HODs. And I would want to also advise that we should volunteer information. If you don't have information, we may not be able to act. If we have information, these HODs, they are our people too now. They are pharmacists. We interact with them. So we'll interact, we'll talk. Because for some of them, it may not even occur to them that, okay, maybe, because some of them will tell you that, oh, you are a pharmacist, you should be able to function anywhere in the hospital. And this consultancy thing now is encouraging specialization. So we should shift. We should not be so fixated to what we were doing. Because like someone said, even the people that have appointed us, the people that we work with, they actually want to see that this subspecialization, not that the one that, okay, today you are working in a cardiology, tomorrow they bring someone else. And, it doesn't give room for continuity. And in pharmacy, there actually must be continuity in transition of care. So if you are not empowered, if the person has not been so empowered, the person may really not be, may not be able to perform. But somebody that has taken it upon himself or herself to empower herself, I think such a person should be properly placed and recognized. So that's what I want to say on that. And even though I know that I'll still yield the floor for my Oga here to, add to what I have said, and Dr. Dan Raka, but I also want to make comments on Dr. Agawa's submission on pharmacists, fellows in academia being paid the consultant allowance. Before you even get this consultant allowance, you must be appointed first. So I think that is where we should start from. I remember at the AGM in Dabo, this issue came up. And I remember Pharmacist Akintayo mentioning that it's even the Napa people that actually shot themselves in the, yes, I remember him saying that when maybe the PSN made that suggestion and the Napa people were against it. They didn't What did you say? Okay. 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 Okay.
They don't see why you should. But a number of us are actually there. And the pioneers of the college, the likes of Professor Opara and all, they are there. We are not earning this thing, and it's very painful.
Okay.
There's a way out. That's what I'm.
Yes, there's a way out. I think I missed it up. It wasn't even at Dabo. It was at the colloquium that this thing came to the fore in Adamawa, and I think PSN is taking it up. So let's see how it goes. I know the leadership of NAPA.
Thank you, Chairman. With your permission, I think it's just to add that the issue of academia assessing the specialist allowance has to do with salary scale. If most people in academia are not on CONHES, the academia that are like linked to teaching hospitals, they are the ones the teaching hospitals can pay them honorary consultant allowance. Usually, that's what the CONHES salary circular advocates. But I know at the level of PCN and many advocacy conversations, there are issues on how the academia in their own rights, that is in their own salary structure, such specialist allowance should be included, which is still in the conversation, because the only available allowance for consultant is only in CONHES. And academia persons are not on CONHES. So it's almost impossible to pay somebody who is on CONRISE or CONWAS to pay him CONHES allowance. The only window is for those academia that are appointed as preceptors in teaching hospitals. Those teaching hospitals can now pay them honorary consultant allowance, which is what they do for doctors that are in academia, but giving services in teaching hospitals. So I am aware, and the PCN is on it. NAPA at the highest level also are conversing, as my chairman rightly mentioned at the colloquium. That's the addendum I wanted to make. Thank you.
Okay. Thank you very much for the addition. Dr. Obono. Okay, over to you. Thank you.
Yes, thank you, everyone. I think the addition I want to make here, most of the explanations are fine and targeted to the question. I want to talk about the community pharmacists. The community pharmacist who has gone through the college has empowered himself or herself and is a CEO of his or her company and can take up the title of consultant. You print your card, your complimentary card, and put there consultant pharmacist. And pay yourself as such. And this is where the value comes in. Now, what is the value I'm talking about? I attended a training by Farm Alliance, Pharmacist Shino Panu at Ibadan. Ibadan people are doing well in community pharmacy. Oh, sorry. Ibadan people are doing well in community pharmacy. I mean, they don't need anybody to label them consultant. They are. I mean, when they told their story, about 2 or 3 of them came up to tell their testimonies, started with one community pharmacy. In no time, they have opened up 2 more. Some have up to 8. They are into veterinary medicines sell. Some have bakeries. Some have food courts. Some have chosen to identify with diabetics and provide care for, things like that. You don't need anybody to come. If you want to do short-term courses in the area of your interest, you go ahead and do that. And you're not waiting for any government, anybody to approve you or give you a label. In fact, the people I saw there, the ones I interacted with, they don't need anybody to come and give them any title. They're already doing well. What the course or training we went for was how to what was the term they gave it? How to expand your scope. How these people got to open up more pharmacies, have more employees, and do so many other things. They were giving us ideas as to what you can do to earn more than just dispensing medications. So pharmacies, the training we have is so much that we cannot finish utilizing them. It just left for you to think outside the box or get what others are doing and start implementing. If you need to go for further training, you do that. Some people are into water sale. Some are manufacture. So many things that they are doing. Some are into animal husbandry and as well as the veterinary medicine or veterinary care they are providing. Veterinary doctors come there to get products from them. Those into bakery, confectionery, so many things. An example is Vanguard Pharmacy. I think as at the last count, I don't know whether it's 14 branches he has. So that's what I want to add. You have been empowered as a fellow. You've gone through the training. You have chosen an area of specialization. What can you make out of it? At least I remember that I'm sure other religions have it, but the Bible says, what do you have in your hand? That is what you need to make use of. You're not waiting for something from outside. All right.
Thank you very much. Oh, sorry, we will not be able to take more than, that last question because I'm getting non-verbal feedback. The day is fast spent. People are tired. And tomorrow is another day, so we have to go home. And it's a raining day in Lagos. Once it rains like this, I'm not trying to scare any one of us. If we leave here now, we may not get home on time. So after his question, the remaining conversation will take it to the platform. So if you are not on that platform, just maybe even if you are not able to come on board today, tomorrow, please. You can meet any one of us. You can meet me, Dr. Dan Raka, Pharmacist Zuwera, Pharmacist Ugu, Timmy. you can meet her so that we can actually bring you on the platform. So after his last question, we'll call it a day. Thank you.
Thank you very much. Mine is not actually a question; it's just a suggestion. After listening to what my colleagues, pharmacist Ibrahim has experienced in their hospital in the quest to be appointed a fellow, a consultant, I feel that this fight should not be left for ASCON alone. PSN should get involved, because I don't think that in medical profession where a certain technical group in NMA is fighting for something, and somebody that calls himself a doctor will be there to ask and to obstruct their efforts or to oppose them without getting sanctioned. I think PSN should not be leaving those HOD or whoever they are like that. They should be reported to PSN and be made to face disciplinary pressure. I think with that, it will serve as a deterrent to other HOD, other chief pharmacists. So we should not just leave it for ASCON alone, because it doesn't make sense that this is a fight for the profession. It's not just for people, it's for generation to come. Then somebody cannot, because of his selfish interest, and be causing fight to it. So PSN should not just stay aloof and not to intervene. So such thing they should intervene, should be that kind of pharmacy should get sanctioned. Thank you very much.
Okay. Thank you very much. It is noted. And if really you listen to my submission, my response to the concern, I said we would actually interact with these people. And if we are not able to get them to correct what needs to be corrected, I said we would escalate. And if I say we are escalating to PSN, because like we are an arm of PSN. So if we are escalating, it's PSN will still escalate to. But it would not be too good for us to just, burden the PSN over issues that we on our own can resolve. It may be like when you speak to these people, like I said, it might not have occurred to them that they are actually doing the wrong thing. But when you talk to them, they may see, they may see sense in what you are discussing with them, and they may change. If they have changed, there will be nothing to escalate now. So let us just take it up. It won't be too good for you to just, go to report straight like that. Let us just talk to ourselves. Like we said, we are we now. We know ourselves now. So I don't believe that we cannot actually talk to ourselves. But if need be, we would escalate. Thank you very much. So I would want to appreciate everyone who has stayed back for your time. It would have been very good for us to continue. But like I said, our time is fast spent and we must close and go home so that we can get ready for tomorrow's program. So on this note, thank you everyone for coming. And the prayer is that the Almighty God continue to strengthen us, continue to keep us so that we can do much more for our profession. Time, 9 a.m. Tomorrow's session starts by 9 a.m. Please let us try and come very early, because, like you can see today, the hall was almost filled and a lot of people didn't come today. But tomorrow being the opening ceremony, the hall is going to be very full. So if you are not here on time, you may have to, stand up for the whole thing, because I was discussing with our chairman, Dr. Adeshino, and I was like, tomorrow I have to come here very, very early, because from what I'm seeing, a lot of people would have to be standing tomorrow. So thank you for your time. We really do appreciate you. Okay, let's have a group photograph. Okay. Pharmacist Zara.
Timmy, let's go.
you.